अपने आप देख लीजिए जो दे दो। दिस मीटिंग वो गोट इट कर दिए ना, गोट इट, दिस मीटिंग इज लाइव स्ट्रीम। एक मिनट, हाँ अब आएगा, अब अनम्यूट किया मैंने। आ रही है आवाज? हेलो, आ रही है ना आवाज हमारी? चलिए ठीक है, मैं और लोगों को इंटर कराता हूँ, उसके बाद आप रहिए अभी व्हाट्सएप पे, और लोगों को इंटर कराता हूँ, ठीक है ना? एडमिट ऑल, जस्ट होल्ड ऑन। डॉक्टर इरफान, डॉक्टर इरफान, एम आई ऑडिबल? डॉक्टर अर्पिता, एम आई ऑडिबल? Unmute your device. Dr. Arpita, am I audible? Ma'am. Dr. Wasim, am I audible? Can you unmute your microphone?
Yeah, very good afternoon to one and all, and you are very much audible.
Dr. Wasim.
Yes, sir. Hello.
Hello.
Hello. Hello.
हेलो, अरे मेरा ही मतलब मेरे ही माइक्रोफोन पे आवाज नहीं आ रही है, ये हेडफोन लगाने के बाद भी। ये इश्यू हो रहा है। अच्छा, दूसरे लैपटॉप से हो जाता है, ठीक। सरफराज, तुम्हारा मीटिंग है क्या? मेरा कुछ इश्यू आ गया, दूसरे लैपटॉप से कनेक्ट। एनुअल लैपटॉप है 5 दिन प्रोग्राम किया मैंने, इससे पहले भी किया।
क्यों, क्या हो गया, क्या सिस्टम में?
मेरी आवाज मतलब कुछ नहीं सुनाई पड़ रहा है। हाँ, मेरी आवाज नहीं सुनाई पड़ रही। मैं दूसरे इससे ना रूम से जाऊंगा इससे। उसको चलता रहेगा, इस पे भी आ जाऊंगा सिस्टम। एक काम करता हूँ, इसमें व्हाट्सएप खुला है तुम्हारा? व्हाट्सएप खुला है?
इसलिए कल का मैंने सब वही रख दिया। 3 बजे शुरू होगा तो कौन बोलेगा?
क्या
3 बजे शुरू है तो?
हाँ, 3 बजे इरफान का क्या बोलेगा तो? ये मैंने तुम्हें भेजा है, मेरा क्लिक करना। डायरेक्ट चला जाएगा वो। Dr. Irfan, there is some issue in my headphone, so I'm connecting with my second laptop, alternate laptop. So hold for a while. I'm just doing that.
Okay, no problem.
वो तो क्या लाइट नहीं आ रहा कैमरा सही से देखिए कैमरा देना जरा सा लगेगा क्या कैमरा छोड़ दे रहे हैं लाइट खाली इधर कर दो
So Nurul, all
yes Dr. Irfan now you can proceed there is some issue I'll try to am I audible Dr. Irfan
yeah, you're ready. So with permission from the Principal Consultant, National Health Academy, I myself, Dr. Irfanul Haq, welcome you all on the occasion of the Nascon, that is National Conference of Sleep, which will be held for 2 days, that is today and tomorrow. As very well said by Benjamin Franklin, early to bed and early to rise makes a man healthy, wealthy and wise. But is it possible for everybody to go to bed and get a sound sleep? No, it is not like that. Many of people nowadays are suffering from the sleep disorder. So we have gathered here from the various fraternity of the medical sciences, and even from apart from medical sciences, the other people have also joined. They know the importance of sleep, and they know, and as a doctor or as an orthodontist, we do play a role, especially in the cases of the obstructive sleep apnea, that also hampers the sound sleep of the person suffering from obstructive sleep apnea. With these words, I would like to welcome our principal consultant, Dr. Nurul, for the inaugural speech. Dr. Nurul is an alumnus of AMU and BITS Planning. He is a visionary, genuine leader, author, public speaker, health inventionist, and entrepreneur working in the management sector pertaining to healthcare industry for the last 2 decades. His specialty domains include health education and communication strategy. He has maneuvered many public health programs and projects all across India. In addition, he is a policy wonk and a keen reader. Presently, he is the principal consultant of the National Health Academy. With these words, I would like to welcome Dr. Nurul Anwar for the inaugural speech. Over to you, Dr. Nurul Anwar.
Good afternoon, everybody. There is some technical glitch that is happened. That's why it's a bit delayed by say 5-6 minutes. And we think that we have I think 25 participants already joined. We have some 100 registrations so far, and we are expecting as we move on we would be getting more participants and all. But as per a schedule, we are moving ahead. Thanks. Welcome you all to National Sleep Congress 2022, and we have just celebrated World Sleep Day on a last week, and on occasion of that, we are organizing this National Sleep Congress. This is the first time National Health Academy is organizing this. Am I audible, Dr. Irfan?
Yeah, you are audible.
Yes. Okay, thanks. So before going into detail, let me introduce one of my colleague, Dr. Irfanul Haq. Dr. Irfanul Haq is an orthodontist, and he is assistant professor in Hazaribagh Dental College. He is president of Indian Dental Association, Hazaribagh. He has worked in as a lecturer in Aligarh Muslim University, and now he is assistant professor in Hazaribagh Dental College. And he is having a long experience in orthodontics, and he would be moderating our first session. And after that, Dr. Anwar from Physiology Department of Jawaharlal Nehru Medical College, AMU Aligarh, would be joining shortly after first 2 sessions. So thanks, Dr. Irfan, to introducing me. Just to say about why we have organized this, that sleep medicine is now an emerging rather it is being established in bigger cities and all. And if you talk about the sleep and all, I'll take you through a history. In the history, we have multiple things which has happened, and just to let you know, we are coming across there's a war is happening between Russia and Ukraine. So there is a nuclear plant in Ukraine. When the USSR was not divided, they were united. In 26th April 1986, I'm taking through 80s, a generation back, that there is a Chernobyl nuclear plant disaster happened, and I'm let you know why this had happened. Then there is a one space shuttle which is being launched in 28th January 86, and it is also there is some mishap happened, and then there is the Exxon Valdez oil spill. So these three all disasters are due to less sleep of the employees, the managers, those who are working for this project. So what happened that in Chernobyl nuclear power, the people who are working over there have 13 hours of their shift and all. They get very tired, and when people are having not a good sleep, they don't have a better decision making ability, and due to this there is a huge mishap happen. And we all know about this nuclear mishap which has happened some 40 years back. Then there is a space shuttle. USA is sending a space shuttle to the US in a space, and just launching from the Earth within 70 minutes, it get crashed actually. Again, the thing is that because they have to maintain the launch date and all, and the people who are working in the team are working tirelessly. They are not getting good sleep, and again there is some issue in a decision making, and this disaster happened. All 7 crew members died. And there is a one Exxon oil shipping company. They are sending some 1 crore of US gallon oil to some other countries and all. And in a midnight at 7, some around 12:05 a.m., this had happened that the captain has a not good sleep and all, and due to it had get stuck, collided in a reef, and then 1 crore gallon US oil is being spilled over the sea, and it took another 3 years to get that sea clean and all. So see how sleep is important, that if we have not a proper sleep, we would be so we should learn from history that what things we are coming across, and what mishappening happened in our past. So if we don't have a good sleep, we have inability to focus, reduced motivation, then we have compromised problem solving, confusion. We would have a irritability, then we may have a memory losses, diminished reaction time, and loss of empathy. We have so far as the disease and other diseases concerned, we would be getting due to low sleep is a heart attack, stroke, then hypertension, obesity, diabetes. These are the incidents, and the sleep causes these diseases to aggravate further. Then if you talk about the incidence of sleep, in 1 in every 3 Indians is having low sleep, and they are not able to get proper sleep. And we are the worst country after Japan, that where the sleep is being deprived in their citizens and all. So the Indians are not able to sleep more than 7 hours a day. So this is again the issue. Then if you talk about the insomnia is in every 1 in every 3rd patient, we are 1 in every 3 patient we are getting the problem of insomnia. It is very widespread. People are not talking much about this. There is a very less awareness among this. So far as this other OSA is concerned, there are some more than 80 sleep related disorders are there, and the physicians, all different specialties, people are treating them, and but the awareness level is low, very low. If you talk about the people who are going to the OPDs of various doctors, physicians and all, only 2% of the patient is communicating to their physician that they are having some issue with the sleep and all. So this is the problem we are facing a lot. Then if you talk about the economy related to the sleep, that the world is losing more than $1 trillion due to sleep deprivation. If you talk about any country, they are losing 1.5% to 3% of their GDP, the taxpayers' money, due to loss of sleep deprivation. So see how huge this problem is. This, if we able to manage somehow, we'll able to save $1 trillion. You would able to increase. It would be used in other medical things, other progress of the country, because every country the people are not able to sleep and they are losing 1.5 to 3% of their GDP only due to sleep and all. So this is how we are facing problem related to sleep. So there is a national health policy which is being amended in 2015 after 15 years, and there are some recommendations from various the experts and all who are working in sleep, that we should have a good awareness in sleep domain, awareness level among even health care professionals, the students who are working in medical fraternity, and the people, the general public. We should make them aware that at least 7 to 8 hours sleep is very essential, because if they have not a good sleep in the previous night, their decision making ability is very diminished, their empathy is down, their quality of life is diminishing, reducing. So we have to, as a physicians, as a clinicians, as a neurologist, as a psychiatrist, as a ENT surgeon, we have a neurophysiologist, physiologist. We have to think, we have to make people aware about how sleep is important, because it's not people are not much aware, and this is the creeping problem, and people are unattended, we are not giving the treatment and all. Then we have a good regulation. I have just spoken that a 13-hour shift lead to Chernobyl nuclear disaster. So we have in our country, there should be a good regulation. In that regulation, we should the government should ask that in the transport, in the aviation, in the hospitals, in the police department, that there should be a proper shift. There should not be a long on a stretch working hours, so that it is diminishing the sleep, and then the productivity is going down. Then we have a very good training program to all our healthcare professionals and those who are related to in the sleep category. Then we should bring this sleep medicine in our curriculum, be it a UG or PG, in a MBBS or in a MD. We should have these things and all. So so far as this we should include it in our curriculum. Then we should have a good availability of the sleep lab, sleep medicine lab. It's unfortunate that India is such a big country of 1.3 billion population, and we have just 500 sleep centers. So we have to increase our capacity, we have to do capacity building, we have to make people aware. So that's why National Health Academy brought these all specialists on a single platform, that they should exchange their knowledge, and they should communicate to the the all stakeholders, the patients, the healthcare professionals, the policy makers and all, so that we have a better sleep and we become a healthier India and all. So with this note and all, I thanks all our moderator and all, so that giving us opportunity to talk in this forum. And now hand over to Dr. Irfanul Haq again to take it forward. Thank you, Dr. Irfanul Haq.
Thank you, Dr. Nurul Anwar. Nice words, and it's really very amazing to know the historical background as well as the importance of sleep from Dr. Nurul Anwar. Then we move forward to our first speaker. The first speaker for the day is none other than Dr. Shah Muhammad Abbas Wasim. He is a thorough clinician and academician. He has completed his MBBS and MD from prestigious Jawaharlal Nehru Medical College and Hospital, AMU Aligarh. After completing his MD, he worked as a senior resident from 2010 to 13 in AMU itself. During the tenure, he learned a lot from his teachers and seniors. He was actively involved in neurophysiology lab of the department and conducted various tests like MNCV, SNCV, BAEP, and EMG. After completing his senior residency, he joined IIM SR, Integral University, Lucknow, as assistant professor in 2013, where apart from academic duties, he was actively involved in administrative and extracurricular work. He worked there till November 2020, after which he joined JNMC AMU Aligarh as an associate professor in the Department of Physiology. Dr. Shah Muhammad Abbas Wasim has keen interest in learning, teaching, and research. Apart from that, he has been the examiner for the BDS, MBBS, physiotherapy, and he has set the papers even for the PhD programs. And apart from this, he is also worked with the whatever organization he has worked with. He has also seen the administrative part as well. He has numerous publications to his credit. And with these words, I would like to welcome our first speaker for the day, that is SMA Abbas. His topic for the today's presentation is, I can see on the screen, he has shared his screen, is physiology, pathophysiology, and epidemiology. Over to you, Dr. Abbas.
Okay, a very good afternoon to one and all. And thank you, the National Health Academy, for giving me the opportunity. So I will directly start with my presentation, because there are lots of other experts on the sleep medicine who will be dealing with the different aspects of the sleep. I am just, I have prepared the slides keeping in view the target audience, because I was told by the National Health Academy President, Dr. Anwarul, that the target audience will be UG and the PG as well as residents, because they are experts on the sleep to speak about. So they will be the apt person to speak on those. So I will just be sharing the basics of the sleep. So my topic of presentation is sleep physiology, pathophysiology, and the epidemiology. I hope the slides are clear and I am audible. Hello.
And slides are visible.
Okay, thank you. And also tell me if the slides are moving. Okay, the slides are moving. The slide is moving. Hello, sir. I hope the slide is moving. Hello. I hope you are seeing the slide is moving. Just
no,
give
slide
me a
is
feedback.
Not moving, Dr. Abbas.
The slide is not moving. Okay, so what should I do so that it moves?
You go to the slideshow and let's check out.
I have gone to the slideshow.
But what we can see, it's not in the slide. So what to the screen you have shared, it's not showing that you are in the slides.
Okay.
Dr. Nurul, some technical issues, guide him, please.
Because I can see the slide here are moving.
But slides are not moving, what I can see.
Okay, sir. And now it is moving?
No, it is still in the first slide. So what you can do, you can close your presentation, again open it, and don't keep it in the slideshow, and just click one by one the slides. Then the slides will be moving, I think. Otherwise.
Okay. So I have stopped the sharing.
Yeah, again you share this slide.
Okay, now I will again share the screen. So I think it's visible.
It's visible. First slide is visible now. You move the slide.
Yes, now it's moving.
Now. It's moving.
Okay. So sorry for the technical glitches.
It's okay.
So first of all, let us revise our basic knowledge of the sleep. That what is sleep? From the medical perspective, sleep is the active state of unconsciousness produced by the body where the brain is in a relative state of rest. But however, it is very important to know that it responds to the internal stimuli. And from the psychological point of view, it is a circadian state characterized by the partial or total suspension of the consciousness and voluntary muscle inhibition and relative insensitivity to stimulation. And of course, each sleep has got its characteristic EG pattern. So this is the basic definition of the sleep. And as we all know that sleep is divided into the rapid eye movement and the non-rapid eye movement sleep. The rapid eye movement sleep is a paradoxical active sleep, and it is because its EG activity is similar to that in awake state. But how the only difference is that the threshold for the awakening is raised. That is, the stimulus you give to alert the person is high, and it has got the fast mix low amplitude EG activity, whereas the non-rapid eye movement sleep is a low frequency high amplitude. Okay, the low frequency, high amplitude EEG activity, non-rapid eye movement sleep, and it is a synchronized activity. In rapid eye movement sleep, the muscle tone is reduced and the respiration is irregular and shallow as compared to the non-rapid eye movement sleep, where because of the decrease in the sympathetic activity, there is decline in the heart rate and the blood pressure. And the variations in the blood pressure and the heart rate as well as the respiration are more in the rapid eye movement sleep. And it is very important to know that towards the end of our sleep cycle, it is the rapid eye movement sleep which helps in the arousal. Okay, because towards the end, the non-rapid eye movement sleep, especially the deep stages 3 and 4, they decline and the REM sleep duration increases. So the person awakes in the REM sleep. Okay, and there is narration of the dream. Because rapid eye movement sleep is associated with dreaming, and the person can give an account of the narrative dreams. He can or she can give the account of the dreams. So these are the basic differences between the REM and the non-REM sleep. And then we come to a sleep cycle. As you can see in this diagram, it's a very simple diagram and self-explanatory that we know when we are awake, then there is the EEG activity is high frequency, low amplitude and desynchronized, and it is beta waves. But however, as soon as we close our eyes, it is replaced by low frequency, high amplitude, synchronized EEG. That is alpha wave. And as we increase the duration of the sleep and we go deeper into the sleep, there is theta waves activity and little or no body movement is seen because the tone of the muscle start decreasing. And the other characteristic pattern is that the basal oscillations, which are less than 5 Hertz, slow waves on which sleep spindles are superimposed. And there is negative sharp deflections known as K complexes followed by the positive component. That is deep sleep. That is stage 3 and 4. We are going towards the stage 3 and 4. And in deep sleep, always remember that the threshold for the awakening is very high. And if the person is awakened in that sleep, that is in the deep sleep, slow wave sleep, then there is a state known as sleep drunkenness, that the person is confused and disoriented. So this sleep cycle lasts for 60 to 90 minutes. And then there's a transition again to the low amplitude theta-like and alpha waves. There's a mixed pattern and the muscle tone goes on decreasing, and there is rapid eye movement sleep. This means the EEG is now again desynchronized. But however, since I told earlier that it is a paradoxical sleep, the sensory stimuli which is required to awaken the person in the rapid eye movement sleep is more as compared to when the person is alert and awake. That is why it is paradoxical sleep. And another characteristic of the REM sleep, as you can see in this figure, is PGO, that is pontogeniculo-occipital spikes. These are large phasic potentials, and the cholinergic neurons in the pons through the lateral genicular body of the thalamus give the signals to the occipital cortex. So this sleep cycle in a normal healthy person, as it was told earlier by the Anwaral in the introductory speech, that around 7 to 8 hours sleep is required for an adult, and 4 to 5 cycles are repeated. Initially, there is a rapid eye, non-rapid eye movement sleeps, 1, 2, 3, 4 stage, and then REM sleep. And as we go towards the night, that is as our sleep cycle increases, towards the morning, the REM sleep duration increases, and the stage 3 and 4 of the non-rapid eye movement sleep, they decrease. Okay, and these are 4 to 5 cycles, each lasting for 70 to 100 minutes. And initially, always remember that the REM is short and non-REM are longer, but however, towards the end, the non-REM stage 3 and 4 decline and the REM duration increase. And then we come to the next slide. As you can see in this diagram, melatonin. I hope everybody knows that since this lecture is an overview of the sleep physiology and pathophysiology. So melatonin has got a very high potential because it is a circadian rhythm, suprachiasmatic nucleus of the hypothalamus, as everybody knows, give the signal to the pineal gland, and then there is release of the melatonin. This melatonin play a very important role in the regulation of the sleep-wake cycle. But however, it is protective against parasomnias. It has got neuroprotective role because it increases brain-derived neurotropic factor. It is anti-apoptotic. It reduces the sleep apnea-induced hypertension and cardiovascular diseases because it promotes sleep. It increases the quality and duration of the sleep, and it is able to cross the blood-brain barrier. It increases the REM time, and it inhibits the ACE activity, okay, bradykinin and the ACE activity. So it is protective against the hypertension also. It stabilizes the angiotensin 2 and protect against chronic intermittent hypoxia, which may result from the intermittent sleeping or the frequent awakening during the sleep cycle. And it also reduces the latency of the sleep. This means the time latency is actually the time from the non-REM stage 1 to till the REM sleep occurs. So that melatonin improves that latency, and it improves the quality of the sleep. So that is the role of the melatonin. And as a researcher, it is a very fascinating molecule, melatonin. And there are lots of research which are available on that, and especially the circadian rhythm, because they have phasic circadian rhythm, and then there are different types shift circadian rhythm, and this is 24-hour clock which is generated, and melatonin play a very important role in it. So if we go towards the next slide, then we find that I hope this slide is moving. Okay, the slide is moving. So as I was telling that now when we know about the sleep cycle, till now we have talked that what is sleep, and we have talked about the sleep cycle, that is REM, non-REM transition, and the role of the melatonin, because it improves the melatonin which is secreted from the pineal gland play an important role in sleep-wake cycle. So now what is sleep all about? Why it is very important for us to sleep? Because sleep has got lots of evolution, and it is still in a stage of progression, and lots of research is being done in it already. And there are lots of sleep scientists and the sleep experts which are doing the research on it, and they will be talking in later talks in this symposium and seminar. So function of the sleep, the first important thing as we look at that sleep cycle, that initially there is non-REM, then REM. So why it is so that REM follows the non-REM? Because the answer is very simple, that non-rapid eye movement sleep is a state of deep unconsciousness and unresponsive state, because the threshold for the awakening is high. So it is very important that there should be a stage in between, in which it is a paradoxical type of sleep, in which from which the person can be aroused. So that is why REM sleep is important. And REM, this transition between the non-REM and REM plays an important role in maintaining the neuronal integrity, and provides a stimulus to the cardiovascular and the respiratory system, because the system during the non-rapid eye movement sleep, all the parameters of the body function actually get suppressed. Okay, and they reduce. For example, as I told you, that there is vagal activity, and the blood pressure and the heart rate and the respiratory rate gets suppressed. Okay, so that is why it is very important to follow an irregular pattern. That is why REM sleep follows non-rapid eye movement sleep. And as we all know, that the rapid eye movement sleep is associated with the loss of the muscle tone. And it also play important because when the muscle tone is reduced, it conserves the energy, because the metabolic activity becomes low, because the now muscle is in a resting state. The tone is reduced and its metabolic activity is reduced. And this also plays a very important role in reinforcement of the neuronal circuit, and play a very important role in learning and memory. And sleep has very vital role in improving your executive skills and providing psychosocial and emotional stability, and reducing the and the prevalence of the stress and anxiety. There is fall in the core body temperature because of the heat loss. This means the sleep has got role in the temperature regulation also. And there is increase in the level of the hormone, like the melatonin, growth hormone, prolactin, and the testosterone. And the cortisol level actually gets suppressed. So there is more towards the feel-good hormone, and those hormones which are anabolic in nature. For example, the growth hormone secretion is very high during the slow wave sleep. And what is the role of that sleep spindles? Always remember that sleep spindle, which I talked earlier, which are superimposed K complexes on the slow waves. They are faster and longer as the sleep progress, because these are the characteristic of the deep sleep, slow wave sleep. And they play a very important role in consolidation of the memory. And they also block the transfer of the sensory signals to the level of the thalamus. And they play a very important role in consolidation of the sleep. That is, we say deep sleep, relaxing sleep. And sleep has got restorative function, it has got anabolic function, and the protein synthesis is enhanced. Other important thing is that the sleep clears the metabolic waste products and removal of the free radicals, which are accumulated during the wakeful state. This means it reduces the oxidative stress. And oxidative stress, as we all know, is implicated in the pathophysiology of almost every disease nowadays. And importantly, it clears the amyloid in the sleep. sleep clears the amyloid, and we all know the amyloid accumulation can result in dementia, Alzheimer's disease. And as it was told by the Anwarul, that deprivation of the sleep is an independent risk factor for the cardiovascular disease. I will talk about later. The cortisol level and the glucose tolerance, that there is a balance between them. There is glucose homeostasis, the insulin resistance is reduced, and the insulin sensitivity and the uptake of the glucose by the cells is increased. And it has been seen that if there is sleep deprivation, then the levels of the cortisol increase, and there is increased risk for the metabolic syndrome and diabetes, because it is an independent risk factor for that. This sleep play a very important role in neurogenesis of the and regeneration of the hippocampal neuron, and play an important role in plasticity, and it plays an important role in consolidation of memory and regulation of appetite and hunger, because it has been found that there is balance between the orexigenic and anti-orexigenic. For example, there is a decrease in the orexins and increase in the leptin during sleep, and it reduces the appetite and the hunger. That is why it is found that the person who have got sleep deprived have got higher level of the orexins and lower level of leptin, so that their appetite is increased, and it can result in the obesity and associated disorders. The REM sleep play an important role in dream, and it has been said that dream play an important role in neuronal development of the circuit development, and it also erases the unwanted memories. It is very important aspect. Dream in itself is a fascinating branch of the sleep medicine. And as I told earlier, that there is reduction in the energy demand, overall psychological well-being, and post-vaccination. It has been researched that if the post-vaccination, the person sleeps, then there is increase in the CD4 T helper cell, and there is increase in the immunoglobulins level. So it has got immune and protective function also. And the sleep starts in the womb of the mother and in infancy also, because it has been found that infants and children sleep for the longer duration of the time, because it plays an important role in neuronal development. So that is very other important aspect of the sleep. Now we come to the neurochemical regulation of the sleep. I hope I am audible. Hello.
Yeah, Dr. Wasim, you are audible.
Okay, thank you, sir. So when we come to the neurochemical regulation of the sleep, the slides are self-explanatory. Just I have to tell that when the person is alert and aroused, awakened, this means there is a role of reticular activating system, posterior hypothalamus, and midbrain reticular formation, because it has been found that ventrolateral preoptic nuclei of the anterior hypothalamus, which is an area of the brain which is implicated in sleep, it is GABAergic. This means it releases the inhibitory neurotransmitter, which in turn inhibits this alerting response and induces the sleep. So this is the neurochemical regulation of the awakening. This means role of the RAS. And it has been found then when there is stimulation and increase in the neuronal firing of the basal forebrain and anterior hypothalamus, then the sleep induces. And it has been found that the glial neurons, glial cells, they express the sleep regulatory neurotransmitters and the receptors for glutamate and GABA. And glutamate is excitatory and GABA is inhibitory, we all know. And there is an interplay between the excitatory and inhibitory neurotransmitter, which in turn produce sleep-wake cycle. We will talk later. So other thing is now the awakening response, as I told you, that there is a role of neurotransmitter. As you can see that there is increase in the norepinephrine and serotonin from the locus coeruleus, and raphe nucleus. In turn, there is a decrease in the acetylcholine. So decrease in the acetylcholine and decrease in the GABA, because the GABA, which is released from the preoptic nucleus of the hypothalamus, increases the release of the histamine from the posterior hypothalamic neurons. There is release because the GABA is inhibitory. So whenever the GABA is the inhibitory signals to the posterior hypothalamus are reduced, then the neurotransmitter from there, which is histamine, is released, and then histamine stimulates the reticular formation, okay, and increase the activation of the thalamus and the cortex. So this interplay results in awakening response, okay. Now we come to the non-rapid eye movement sleep, how that happens. It is the role of the inhibitory neurotransmitter from the preoptic neurons of the hypothalamus, GABA. That GABA is increased, which in turn inhibits the release of the histamine from the other areas of the hypothalamus, which in turn decreases the activation of the thalamus and the cortex, and this person goes into the non-rapid eye movement sleep. And it has been found that the increase in the slow wave activity, this because as we progress, the slow waves, non-rapid eye movement is associated with slow wave. there is increase in this slow wave activity with the sleep deprivation. If the person goes into a sleep deprivation, अगर आप सो नहीं रहे बहुत दिनों तक तो आपका क्या होगा, you will go into a deep sleep. एक डीप स्लीप में आप चले जाते हैं स्टेज 3-4 में, क्योंकि जो इनिशियल स्टेजेस होते हैं फिर वो ओवर रूल हो जाती हैं, वो बाईपास हो जाती हैं. Okay, and in that state, and along with the genetic factor, this means the sleep deprivation along with the genetic factor can result in sleepwalking. So this pathway has got something to do with that sleep-related disorders, that is the parasomnia with the non-rapid eye movement sleep. Similarly, if we come to the rapid eye movement sleep, which is the paradoxical sleep, they decrease in the norepinephrine and the serotonin from the locus coeruleus and the raphe nuclei of the brainstem, and then ultimately they result in the increase in the acetylcholine from the pontine reticular formation, which in turn induces the rapid eye movement sleep. Okay, so rapid eye movement sleep has choline, acetylcholine, cholinergic pathways, neurons. They play a very important role in the rapid eye movement sleep, and that is why it is said that the subject is on anticholinergic or there is brainstem dysfunction, then the sleep related disorders, behavioral disorders which are associated with the REM eye sleep occur. So in those subjects who are having anticholinergic, taking anticholinergic, then the REM associated sleep disorders occur. Otherwise, the REM associated sleep disorder are not very common, okay, and prevalent. And sleep scientists will tell about that. And other important role of the REM is dreaming. Okay, and how it happens? So it is a very basic idea that increase in the thalamic acetylcholine, because the acetylcholine cholinergic activity is increased during the rapid eye movement sleep, and it suppresses the spindle activity. Okay, the spindles which are produced in the deep sleep, those are suppressed. And at the same time, the acetylcholine, which is increased in the cortex. Okay, what it does, it inhibits the or suppresses the slow wave activity and causes EEG desynchronization and activation of the cortex. So the acetylcholine in the thalamus suppresses the acetyl spindle activity, and the acetylcholine in the cortex, which is increased, causes desynchronization of the EEG and the activation of the cortex. So what happens? The REM sleep results in these sensory inputs to the cortex, because there is activation of the cortical. So that is receiving sensory signals, and then the person can enact the dreams also, okay, and can recollect the dreams also, give a narration of the dream also. So the dream has got very important implication in the part of the rapid eye movement sleep. And other thing, as you can see in this slide, the role of the suprachiasmatic nucleus, which is the biological clock. The suprachiasmatic nucleus biological clock receives the signal from the retina. And I hope everybody knows that retina have got the rods and cone, which are visual pigment, but however, there is non-visual activity also, which is known as melopsin. It is a pigment, but how it is sensitive to blue light. It is sensitive to light. So whenever the light falls on the retina, then melopsin pigments, it perceives that light. And then through the retinohypothalamic tract, it gives the signal to the suprachiasmatic nucleus of the hypothalamus. And these signals are excitatory, glutaminergic. Glutamate is released. And when glutamate is released because of the activation of this pathway, the suprachiasmatic nucleus gets activated and the neuron firing is affected. And there is release of the inhibitory neurotransmitter GABA. And then as we all know that the suprachiasmatic nucleus gives the signal to the pineal gland directly through this pathway, and also through the paraventricular hypothalamus and upper part of the cervical ganglion, which is the upper part of the spinal cord, sympathetic signals. Okay, so and then these are noradrenaline secreting, which affect the cyclic AMP, second messenger system, which affect the activity of the enzyme, which in turn cause the conversion of the serotonin to melatonin. Okay, so let us take an example that light falls on this retina. So what will happen? The glutamate excitatory signals will be given to the suprachiasmatic nucleus. Suprachiasmatic nucleus neuron will fire, and the GABAergic signals will be sent, which in turn will reduce the noradrenaline secretion, so that there will be less conversion of the serotonin to melatonin. Okay, and the sleep cycle will be affected. So this is a biological clock. But however, in the dark, it is stimulated. The melatonin secretion is stimulated. But however, this biological clock has got signals which depend upon the duration of the day in which the signals are falling, because the light in the dark and the dark in the light can affect this pathway. But however, since it is beyond because we have a limited time, so just a basic pathway, and it is sensitive. Always remember, this retinal ganglion cells are sensitive to blue light. And here comes another research that the mobile phone cameras, they have got blue light on that. and they stimulate your melanopsin pigment. It perceives that blue light, and then there is decrease in the release of the melatonin. And when the melatonin secretion decreases, the sleep quality is affected, duration is affected. That is why the mobile phone user who are not using the blue light filters, okay, they may have got sleep disorders also. So this is one part which we have to remember, because this melanopsin is sensitive to blue light. And other fascinating part is that blind person, they can also regulate their sleep wake cycle because it is sensitive to blue light. Okay, it is not like rods and cones, because rods and cones have a visual cycle. It is related to this hypothalamic retinohypothalamic tract. Okay, and secretion of the melatonin. This means regulation of the internal biological clock, which is 24 hours circadian rhythm. So this is another fascinating part. And as we come to the other parts of the sleep, which we must know, if we know the pathway, then this becomes easier for us. Okay, now as we can see that the muscarinic receptor agonist and acetylcholinesterase inhibitor. Okay, because REM sleep, we know that acetylcholine increases REM sleep. So if we give anticholinesterase inhibitor or anticholinergic, then it is going to affect the REM sleep duration and the quality. Similarly, the noradrenaline release from the locus coeruleus can result in insomnia. Okay, noradrenaline secretion, and it is implicated in the post-traumatic stress disorder, insomnia, and the nightmares. Okay, and similarly, the dopaminergic neuron from the periaqueductal gray matter, ventral part, have got connection with the sleep pathway. This dopamine has got the connection with the sleep pathway. We should know that, and they are very close to the raphe nuclei. Serotonin, and serotonin, as I was telling earlier, that it has got role in the wakefulness, and that is why in the certain drugs which are used in the Parkinson's may result in the sleepiness. Okay, and similarly, antihistaminics produce sleepiness because it reduces the histamine level. Okay, so it may produce sleepiness, and histamine, as we go to the earlier slides and we recollect our knowledge, it plays an important role in sleep wake cycle. And similarly, orexigenic neurons, which are firing from the lateral hypothalamus, they are increased during the wakefulness and are affected in narcolepsy. Okay, it has been found that the person who have got excessive daytime sleeping, that is narcolepsy, they have got some defect in that lateral hypothalamic neurons which are releasing orexin, because orexins are implicated in wakefulness. Okay, and similarly, then if we come give a very brief view of the sleep regulatory system, there are certain factors which increase REM sleep, and there are factors which increase non-REM sleep, and there are factors which increases wakefulness, alerting response. And it is important to know, because we can study and develop research on that, and we can also study these parameters in number of diseases in which there is sleep wake disturbances. For example, non-rapid eye movement sleep is increased by the nitric oxide, growth hormone releasing hormone, adenosine, prostaglandin D2, and interleukin and TNF alpha. And it has been found that the person who are taking high fat diet, and if there is increase in the ambient temperature, then interleukin 1 beta and TNF alpha increases, and they have got increase in the non-rapid eye movement sleep. And similarly, if there is sleep deprivation, then the prostaglandin D2 increase, okay, in the hypothalamic areas, and then it increases the non-rapid eye movement sleep. Okay, that is why it has been found that the person, if sleep deprived, go into the deep sleep, okay, non-REM sleep. And similarly, in the rapid eye movement sleep is stimulated by VIP and prolactin. Okay, and similarly, wakefulness, and it is a very fascinating to know, because prolactin is associated with the milk in mother nursing. Okay, and a slight cry of the child, baby, awakens the mother, and we all know that rapid eye movement sleep we arouse from the rapid eye movement sleep during the REM sleep. So it is a nature's way that prolactin increases the REM sleep. Okay, so it is a very correlative and activity. Similarly, corticotropin releasing hormone ACTH and the ghrelin, they are responsible for alerting wakefulness. Okay, and the role of the ATP, it is also very important to know role of the ATP, because ATP increases the sleep promoting substance, adenosine. Adenosine is a metabolic product of the ATP, and ATP binds to the neurons, which in turn produces the increase the secretion of the sleep promoting substances. like TNF alpha interleukin 1 beta brain derived neurotropic factor. And it has been found that if the person are defective in such type of neurons, like neurons having ATP receptor or adenosine receptor, then or the release of the adenosine is affected, then it results in the weaker response to sleep deprived state. This means if the person is sleep deprived, then he will not go into non-rapid eye movement deep sleep. Okay, so it results defect in that. So it has a role in that also. And we come directly to the sleep disorders in brief, because experts will be talking about that. There are lots of sleep disorders like breathing disorders, like fatigue, snoring, insomnia. These are the symptoms associated with it. So if there are symptoms along with the 5 or more than 5 obstructive events, sleep events, obstructive sleep apnea or obstructive respiratory events per hour of the sleep, or with symptoms, or more than 15 without symptoms, then we say the person is suffering from sleep related breathing disorder, like obstructive sleep apnea, which is very common. And similarly, central disorders like excessive daytime sleeping, narcolepsy, okay, hypersomnias, and the effect of the medication, that can also result in the sleep disorder. Circadian rhythm sleep disorders, okay, rhythm is affected. Sleep wake disorder is, for example, shift workers, the persons who are working in the night, okay, or jet lag, okay, and occupational disorders also. So that is that affect the circadian rhythm. Sleep related movement disorder, for example, restless leg syndrome. It has been found that if there are iron deficiency in the specific areas of the brain, or disbalance in the dopaminergic pathway, then there is restless leg syndrome, okay, and REM associated disorders. Similarly, what is the epidemiological factors, pathophysiological factors or epidemiological factor which can result in sleep disorders? Social inequalities, because sleep is a fascinating subject for the social scientists also. Social inequalities, deprivation of the basic amenities, the low socioeconomic status, low education level. It has been found they are correlated more with the sleep disorders. Advancing age, female gender, they are more associated with the sleep disorders. Okay. Similarly, occupational hazard. It has been found that the poor sleep quality and the sleepiness effects can result in the sleep cycle disturbances, as was example was given by Dr. Anwarul of the various mishaps, nuclear mishaps and the other mishaps which have happened, and the accidents, road traffic accident, they result from that also. Hectic lifestyle, the occupational demands, okay, especially for the medical students, for the HR person, for the IT professionals, those working in certain in which they have the occupational demands, the hours of the work are more, they have to do night shifts, they also affect this means the effect of the profession. Excessive traveling, these are the occupational hazards which affect your sleep. Similarly, medical students, if the medical students are part of this webinar, so they should be very aware that they have got some sleep disturbances. They may or may not know it, but how they have to address those issues, because sleep disturbances can result in the, for example, before going to the sleep, every medical student have got the habit of making some doing cognitive activity plans, कि कल मुझे कौन सी क्लास करनी है, अभी मेरा कौन सा होमवर्क रह गया, कितना स्ट्रेस है मुझ पे, ये मेरी तैयारी नहीं हुई है, कल पीसी है, कल एग्जाम है, परसों कंपटीशन है, ओके। इंटरनेट यूजेज, और खासकर 2 साल से इंटरनेट यूजेज चल रहा है, और वैसे भी इंटरनेट यूजेज भी इंपॉर्टेंट है। एज आई टोल्ड यू, smartphone releases blue light and they reduces the melatonin secretion, and of course the academic stress. So medical students have, it has been found in various studies in Asia that 70 to 90% of the medical students have got sleep related disorder. Pandemic, especially the healthcare worker, general population and the COVID patient suffered from the sleep disorders due to the psychosocial distress, fear, anxiety, workload, okay. And similarly, cancer patient, or those patients which have got chronic diseases, okay, and debilitating condition, especially the cancer patient, they have got the poor quality of life, they suffer from the fear of the death, depression, they are on medications, chemotherapy, radiation therapy, they are having these sleep disorders. And similarly, insomnia, as was told earlier in the introductory part, these are the very common sleep disorder, insomnia. And if there are comorbid condition, then the chances are high. For example, if this patient is suffering from cardiovascular disease or musculoskeletal diseases or psychiatric diseases, then the insomnia is very high in them. And gender, as I told earlier, that the female gender is a risk factor for insomnia. Okay. And for example, let us take an example.
Sorry to interrupt you, Dr.
Yes,
Abbas.
sir. Okay, sir.
we are running short of time. Please be concise.
I will take only 5. I will take maximum 5 minutes more.
Okay.
Thank you for the feedback, sir. So let us take an example के type 2 diabetes में sleep disorder कैसे हो सकता है. Type 2 diabetes है तो there is increase in the level of the sympathetic nervous system activity and the slow wave is low. Okay, the patient is hyperglycemic, so there is nocturnal hyperglycemia as well as nocturnal hypoglycemia. So there is frequent nocturia because everybody know polyuria, polydipsia. These are the features of the diabetes. Okay, and neuropathic pain, and of course the effect of the medication because it has been found metformin. It is associated with sleep disorder. So we have to correlate because diabetes may sleep becomes important. Because that aspect should also be touched and talked, and the patient should be counseled and treated for any possible sleep disorder during the course of their therapy and the progression of the disease. Because if the disease progresses, there is hyperglycemia, then the sleep disorder will also progress, and then it will be a risk factor for other diseases. And okay, and similarly, for example, the basal nucleus of the myelin, cholinergic transmission, if that is affected during Alzheimer's disease, since acetylcholine has got role in the sleep, then automatically sleep disturbances will also occur. Similarly, there are certain diseases like progressive supranuclear paralysis, in which locus coeruleus and the raphe nucleus is affected. It will then automatically result in the sleep disorder. Similarly, there are various examples. If you know the pathophysiological, the pathways of the sleep, so it is very easy to understand if any disease which affect that pathway, it is going to affect the sleep. It is going to affect the produce the sleep deprivation. So it is very important to understand that don't deprive yourself of the sleep. Don't feel that sleep is only a recreational activity. And if you are thinking that, then you have to be very alert, because I give you an example that the sleep deprivation may act as an independent risk for cardiovascular disease, metabolic syndrome, diabetes, hypertension, neuropsychiatric disorder. There can be lipid profile abnormalities, dyslipidemia. There will be susceptibility to inflammation, infection, attention, memory, learning will be affected. There will be increase in the production of the free radicals and accumulation of the waste product, endothelial dysfunction and hormonal imbalance. Glucose homeostasis will be affected. There will be increase in the stress pathways. Okay, so this is what is the importance of knowing about sleep and regulation of the sleep. And mind-body relaxation is very important because we know that yoga and meditation directly and indirectly affects almost every system of the body. It has been found that the meditation and yoga reduces the stress activity and improves the quality of the sleep. It increases the vagal dominance and it improves the metabolic state of the body and maintains the heart rate, basal metabolic rate, and reduces the basal oxygen consumption. And it also improves the glucose sensitivity and baroreceptor sensitivity and reduces the oxidative stress and infuses a sense of well-being. And this is the things which the sleep does. These are the physiological functions of the sleep. And mind-body relaxation techniques are just enhancing and reinforcing these effects. One of the best way to have a good night's sleep is doing mental mind-body relaxation technique like meditation, pranayama, asana, yoga. Okay, that is the one aspect which we have to look. And I hope everybody know about yoga nidra. It is the best form of the meditation and inducing sense of the goodness and the well-being. And you should search about yoga nidra. There are lots of videos available on the site of the Information and the Broadcasting Ministry and the Ayush Mantralaya, which talk about these simple pranayama and the yoga techniques to improve sleep. Okay, and this is one of my favorite poems of the Robert Frost, and miles to go before I sleep. But how I always remember that when you go miles before sleeping, that is the effect of the exercise, and it has to be researched upon because it has been found if you do exercise, it reduces stage 2 of the deep sleep and increases the REM sleep. But however, since exercise is associated with increase in the sympathetic nervous system activity, so immediately after exercise, you may not go directly to the sleep because you have to give some time to the body to settle because the effect of the sympathetic should reduce. But how it is well known that exercise improves the aerobic capacity and quality of the sleep and increases the melatonin and improves the body fat, visceral fat, obesity, that is reduced. And of course, as I told earlier, that the mind-body relaxation technique, yoga nidra, one of the basic simple exercise and yoga technique which you can do to increase the sleep quality and the duration of the sleep. So in the end, I would like to say that good sleep habits need to be adopted to allow us to have a better control of our mind, over our mind, of and over our mind, and attain homeostasis and the physiological state. Because if we don't allow your mind to control yourself, your body, have a control over your mind, and what the better way to have control over the mind than a good night's sleep with increased duration and increased quality, good quality sleep. So thank you to the National Health Academy for giving me the opportunity to express my views and share with the target audience, that is the residents and PGs, and of course now expert in the medicine will take on from here. So thank you and have a nice day.
Thank you, Dr. Abbas. It was really very enriching session, and we all enjoyed, and it was a very good revise for all of us what we read in our graduate days, and you explained the physiology and the pathophysiology as well as epidemiology in a very simplest way, and hope it will be very helpful to all the audience who were hearing to you. It was indeed a very nice session, and I with these words I would like to thank you for sparing your time with us. And then we move on to our second speaker.
Thank you, sir.
She is Dr. Arpita Priyadarshini ma'am. Hope ma'am is there. Dr. Arpita Priyadarshini ma'am has done her MBBS and MD in physiology from SCB Medical College, Qatar. And she has been a fellow of American Academy of Sleep Medicine, Cleveland Clinic, USA. She is working in sleep medicine since last 15 years. And she has a vast experience of teaching and research, which is almost 23 years. And presently, she is working as professor and head, Department of Physiology, Sri Jagannath Medical College, Puri, Odisha. Apart from that, she has been a life member of the various academy and associations of India and abroad. To name a few, she has been the life member of the American Academy of Sleep Medicine. She is a life member of Indian Sleep Disorders Association. She is life member of Indian Society of Sleep Research, as well as she is the life member of the Association of the Physiologists and the Pharmacologists of India. She has also organized various workshops and conferences of the sleep. She has been organizing secretary and speaker in SleepCon, which was held in 2018 in Puri. It was an international conference on sleep. She has been the organizing secretary and speaker of the 60th annual conference of the APPI 2014 in Puri. She was also the organizing secretary of the National Sleep Medicine course in 2008, which was held in Qatar. Apart from that, she is also the secretary of the Association of Physiologists of Odisha. With these words, I would like to welcome you, ma'am, on this National Health Academy conference on sleep. Over to you, ma'am. Now you can share your slides and experience and share your experiences with us. Thank you so much.
Thank you so much, Dr. Irfanul, for your wonderful words for me. And I'm really excited to share the screen with Dr. Bindu, who is my akka, my elder sister, who initiated me to sleep in her lab. I did my polysomnography course under her. And I really thank Dr. Nurul to put so many, and Dr. Reena, I see Dr. Reena Kumar also here, one of my closest, I would say, colleague and a great, she a very inspiring personality to be with her. And Nascon, really, I congratulate you for thinking and spreading the science of sleep, which was always a dream for all of us who are working in sleep, because sleep we started very quite a long time back, and it was really rudimentary, but now it has started crawling. I'm very happy, and I think Dr. Bindu must be also very happy regarding how you have taken up to spread sleep science amongst the public and also amongst researchers and amongst everyone who are interested in finding out the normal physiology, how it helps. Now, with the blessing of Ma Saraswati, my Ishta, my work is to talk a bit about a critical role for circadian rhythms and sleep in immunity. Well, my objective is very, very simple. I would like to speak about biological clock as the timekeeper, circadian rhythm disorders, and paying heavily for cheating on sleep, sleep and immunity, crosstalk for fitness. So to begin with, let's make our mind vast to fathom the cosmic spin. The 33.5 degree of tilt of the Earth, the day and night cycle because of the rotation, the seasonal cycle because of the revolution. This is the base for which we have a rhythm in the whole universe. This oscillation not only oscillates in the cosmos, but it shows its activity and the RNA and DNA cycle inside the cell. So the interplay of sun, earth, and moon is the cause of this circadian rhythm. As all of us know, am I audible?
Yes, ma'am, you are audible.
As all of us, am I audible?
Yes, ma'am, you are audible.
Okay. So as all of us know, it is Franz Halberg, this coined in 1950 or 59 the term circadian. And it was seen that this world always goes, our earth goes 12 hours into darkness and 12 hours into light. So this light and dark cycle anchors an organism by creating endogenous autonomous oscillation in association with approximately Earth's daily rotation. So we are hooked not to our money. We are not hooked exactly to the ambition. We are hooked to day and night cycle, light and dark cycle. And that's the word circadian, which means for about a day. And there are many circadian rhythms. One of them is your feeding rhythm, your temperature rhythm. There are so many circadian rhythms happening with changes throughout the day. And sleep and wake cycle is the most important output of circadian rhythm.
Ma'am, your slides are not moving, ma'am.
It's not moving. Now you can see?
It's still in the first slide, ma'am.
Achha. So I'm just a minute.
Yeah.
Can you see now?
It's still in the first slide, ma'am.
Just a minute.
Now it's moving.
Now it's moving. So if I go from the beginning, it's not moving. So this one, can you see now?
Yeah.
Is it visible?
Yeah, ma'am, it's visible.
So we can see this now?
Yes, ma'am.
Okay. So as I was telling that all of us, our endogenous autonomous oscillation is totally dependent on light and dark cycle. And it was first observed by many, but it was Franz Halberg of Romania who found out the chronobiology and the chronobiology laboratory, which not only has done a wonderful work in many things, but the most important endpoint they want to reach is to find out what is the chronobiology of cancer cells, how chronobiology is working on cancer cells, how cells are produced by this oscillation. That is the ultimate they are working on. We hope we get something out of it, but to make it very simple, and this circadian rhythm, which is brought about by the movement, the rotation of Earth around its own axis, and the most important output of circadian rhythm is sleep and wake cycle. It can be manipulated. This circadian rhythm can be manipulated by light and dark cycle, by feeding schedule, and social interaction. So these are the three most important Zeitgeber, which we usually call in German, means timekeepers. So the timekeeper is not the clock which is hanging on your wall. The timekeeper is always the sun or no sun. And the feeding, whatever you're eating, the smell, the sight, and your social interaction is also a Zeitgeber. Why am I giving a bit more impression on this is that your internal clocks are not only regulated by the main solar vortex, but also it is regulated by your feeding activities, your feeding schedules, and your social interactions. That's very important. And these three things are very important to maintain a very healthy life. Now coming to the next. So organismal fitness. Our fitness, where we are going to gym, we are eating keto diets, we are trying to keep our BMI under 25, we want to be mentally healthy, we want to be multitasking, we want to be happier, we want everything under the sun we want. But this is all possible only when your cellular clocks are working properly. So these cellular clocks are conserved from cyanobacteria to mammals, from the unicellular to multicellular till human, and maybe the devas which we have in our scriptures all need a cellular clock for the fitness. And the central circadian pacemaker, as very well said in the previous lecture, so well explained, one of the best lecture I've heard. The central circadian pacemaker is suprachiasmatic nucleus, entrains peripheral clocks present in all cells. Suprachiasmatic nucleus is the only part of the circadian system in opaque mammals, which is entrained by solar cycle. We are opaque. The only portion where the light enters is through the eye into the suprachiasmatic nucleus and to the different pathway, retinohypothalamic pathway through the autonomic nervous system to all the cells. It is because of the suprachiasmatic nucleus we are able to entrain the cellular clocks. So the peripheral clock dampens with time. This is very, very important. The peripheral clocks cannot keep the time. But while suprachiasmatic neurons have unlimited capacity to generate circadian output to reset disrupted peripheral biological clock. So this is the most important thing for juniors who are watching a lot of smartphones and having a different type of lifestyle which is not related to sunrise and sunset. We have to get related to sunrise and sunset only to reset our biological clock present in each and every cell. So each and every cell has a genomic structure which maintains a biological clock. That is why nucleus perishes within your neutrophil perishes within 7 days. So your menstrual cycle is in 28 days. So you have a cyclic rhythmic pattern because these biological clocks which are present in the cellular level is working. Now coming to clock genes. So the clock which is present in the cellular level, it is also working at the genetic level. And all of us know the synchronization of suprachiasmatic nucleus clock by sunlight. It happens only by sunlight, not moonlight, sunlight. It activates the anterior hypothalamus, the suprachiasmatic nucleus, and it gives you a rhythm and training cues, which is also related to feeding, temperature, autonomic tone, hormones and arousals. What they exactly do is they activate the peripheral clock. This is the period and the cryptochrome genes, which is stimulated by this two positive feedback mechanism by which gene expression, all your physiological function, the metabolites are maintained. So these peripheral clocks impart circadian patterns on gene expression and overall cellular physiology. So it is the light, the sunlight, getting up in the morning at the right time, seeing the sunset, that gives you a rhythm in your body and at the molecular level of your body. So as we go to the next slide, this is very interesting. This is the papyrus paper you must have seen in Egyptian culture. This was the first clock. This was the first clock which they tried to, to graphically represent the time sense. And exactly this is what humans have done, and this is God-made, this is man-made. You see the God-made thing, how beautifully it regulates sleep, metabolism, immune response, and even the microbiota, the flora of your gut, your good bacteria is inside your gut, and your cancer, your aging, your cardiovascular system, they are all being regulated by the timekeepers or the clock genes, the period and the cryptochrome genes, which are present in each and every cell, which as you know, every cell has an apoptosis, and they are all maintained by this clock genes. So if this is not maintained, what is going to happen? And we know from the International Classification of Sleep Disorder, you have a big disorder known as circadian rhythm sleep-wake disorder. Time is same for everyone. If you're sleeping early, you have to get up early. That happens basically those who are bored in life. They do not know what to do once the day starts. Basically, I would take you, and I would try to put that word when you take care of your grandparents, the elderly people of our society who really need understanding. We have to keep them busy. Otherwise, they will suffer from advanced sleep-wake disorder. As they sleep early, they get up early, and in the both phases, there is no human around them. When they're sleeping, there's no one around them. And when they get up, everyone else is sleeping, so they're basically lonely people. And this is a common disorder which is basically seen in mentally depressed people and in elderly care people. So if we know how to keep them, we know about this, and we know how to keep them amused and excited about life, we can really give them a good mental health. And now, you know, the population of elderly population are increasing. So we better start thinking about it. Now, this is our phase. I mean, our children are going through this 24/7 society, delayed sleep wake phase disorder. And when India is getting connected with the US and in different parts of the world, so we have to wake up for them. So as you see, we sleep late and we get up late. And again, this totally changes the circadian rhythm, and we have genetic mutation and newer proteins which are not present. Maybe they are the cancerous proteins, because we are used to sunrise and sunset. Only when we are used to sunrise and sunset and the right kind of Zeitgebers, we express the right kind of proteins which are healthy. Now, irregular sleep-wake rhythm disorder, it's very commonly seen with house surgeons, with people like who have lots of telephone calls, and even our children who have been hooked up to what do you call these YouTubers, and so they have intermittent sleep-wake rhythm disorder, where they sleep and get up, and they do not throughout the day, they do not have a consolidated sleep, neither they have a consolidated awake state. They're always in an intermittent, they're sleeping, getting up, sleeping, getting up. This is a very, very ridiculous and a very unhealthy practice if sleep is considered. Now, for the blind people who do not have the Zeitgebers, the light cannot be entrained through the suprachiasmatic nucleus, and usually they have errant sleep circadian rhythm. As you can see, they are known as free running time. They do not know what you call it right time to sleep. So they usually have, they can either be advanced or they can be delayed. But sometimes it happens because of this disorder, they have many chronic diseases cropping up. And all of us know, which I'll be talking later, and my previous speaker has spoken very well about, and even Narul spoke about shift work disorders, and he talked about Chernobyl's and so many things he talked about. In fact, we'll be talking in detail about shift work disorders, because now, because of the economy, I really do not understand what this economy is all about, why we have to wake up like this, and why the country has to work I mean throughout the day. I still don't understand how can a human work in the night for a few days, and again work in the day for some days, again in the lunchtime, in the intermediate time. How it happens, and how our lawmakers are not understanding the importance. It's like, I mean, it's like challenging the life itself when you are challenging the nature. Now, the jet lag, very obvious. World has become one transport facility, and everyone is moving, and we are in different time zones. But our cells don't understand this. Our cells don't understand this. You are in different time zone. Your circadian rhythm is different. Your suprachiasmatic nucleus has sensed the central clock is different. Your local clock is different. Definitely, the expression will be different. So, what happens if we have so many disorders in under circadian rhythm sleep-wake disorder? Who is going to pay for it? We have to pay for it. And we have to pay for our cheating on sleep. As very rightfully said by Dr. Narul, we have to have a sleep pattern, and we must sleep in a particular rhythmic and in a consolidated way. If we are not doing it, what can happen? The commonest disorder which we really face is weight change. Weight change, whether you are lean or you're obese, but you will face, if you are changing your weight every 6 months, it is not being constant at least for a year. It shows that your sleep pattern is not consistent with nature. So what we see, this weight change, as we see the leptin level is disrupted, the glucose levels are disrupted, and weight differences are disrupted, insulin disrupted, and the insulin glucose ratio disrupted. As we see the hormonal balances, which leads to many metabolic syndromes. And to add to that, the obstructive sleep apnea because of the obesity, which again starts the whole cycle of complications to different parts of our body. It's all because of our sleeping pattern or the circadian rhythm, which we have forgotten, or we are not interested, or we do not know about it. So now time has come for the lawmakers to think what to do about this night shift work, what it exactly does. You know, when we work in the night, you know, all of us know by sunset, when we enter into the darker zone, we synthesize or we secrete something very vital and very magical, that is melatonin. And Dr. Huck has very well said about melatonin. I need not elaborate. And this melatonin, because of electromagnetic waves, you know, from where it comes, from all your gadgets, and from artificial light. Previously we had lantern lights, candle light, and now we have these LED lights. And irregular diet. We eat anytime because we have money, we can buy things and we can eat at any time. And impaired circadian gene expressions, they all lead to aberrant epigenetic modification, which leads to hypermethylation. And this leads to activated cell proliferation and transformation, and end result is you cannot control it anymore. When you lose a control, you can call it as a cancer. The cells cannot control its own self. Now it is not under any control system. And it's all because of simple things which can be avoided. Now, shift work is, this is a big statement. Shift work is a potent carcinogen. It's a potent carcinogen. Chances of developing breast cancer in shift work in Europe is 1 in 9. If you are a long-term shift worker, it is 2 in 9. And shift works are related to heart attacks, obesity, and strokes. As very well said by Dr. Narul about the Valde, about the Bhopal tragedy and the Chernobyl, and the most important we have forgotten is the freedom of at midnight for India also, where we were cut by, and we were taken, I mean, the Bangladesh was cut from us, Pakistan was cut from us, it all happened in the night. So we cannot forget, if anything, any lawmakers start taking decision in the night, what can happen? So we must have seen in many places our oldies whom we think they're idiots, stupid, they give water to sun in the morning. And in fact, that was all about entraining your suprachiasmatic, the central clock, so that all the internal clocks to be entrained. You could recite some mantras related to sun and see the sun, get it through you, and set all your internal clocks back into reset it. So this was what which we called rituals. They're not rituals, they're pure science. Now coming to the last part, the sleep and immunity crosstalk. They are bidirectional. As you see, circadian system has control over autonomic nervous system, which is not under your control, and neuroendocrine system, which is under your control, some part. And they maintain your sleep, and they also maintain the immune system. And the immune system maintains your infection and your disease or health state. Earlier, it was seen that many in the PubMed, if you see, earlier in 1990s and all, more publication was about chronotherapy and immunity, circadian and immunity. But now it has come, they have touched the point, and they have started thinking about its sleep and immunity. And sleep in Lancet, in Nature, it was, this line was very, very touching to me. And I always remember, and I always recite it, that sleep is of the brain. It is a marker of the brain. If your brain is working properly, brain, the whole thing, sleep is of the brain. It is by the brain and for the brain. And it's happening, then the whole body is the beneficiary. So sleep is one of the physiological function that benefits each and every part of your body at the molecular level. And this is the hypnogram, which you get it in polysomnography. But here I want to show you that as we age, at 20 years old, you see within four minutes you're sleeping. Say with no time you're sleeping. But as you grow, you see your sleep latency increases. You take time to sleep. But as you grow, your slow wave stage 1 does not change much. Neither your stage 2 changes much, but your slow wave sleep, the stage 3 changes, as well as your REM sleep also changes with aging. Why am I always hinting at aging? Because most of us neglect aged people. Most of us neglect our aged parents and grandparents and relatives. They have the basic sleep problem. We should address them very early if we are sleep conscious. And the model of sleep-immune interaction, as you know, because of primary insomnia, sleep apnea, major depression, alcohol dependency, you have sleep disturbances. And because of sleep disturbances, your pro-inflammatory cytokine levels and production increases. Your natural and cellular immunity decreases. And because of that, inflammatory and cardiovascular disorders, particularly your endothelial dysfunction related disorder, your vascular disorders related to different parts of your body starts, even the nephropathies, your eye changes, whatever you know about the inflammatory changes happens. And there is infectious disease risk, which most of us know when COVID visited us and still visiting. We are at risk to infection. Infections were always there. Coronavirus was always there because in 1990s when I was doing my MBBS, we had read in Davidson. It was always there. But the risk of getting infected has increased. Maybe we are not taking care of the most important vital function, that is sleep. Now coming to the big announcement, sleep is always not a very, very sweet or a very lush green field. It has its own, cut edge. Sleep is a pro-inflammatory state. As you see here, as the night goes on, the inflammatory markers increases. The interleukin 2, the interleukin and the tumor necrotizing factor, and the anti-inflammatory markers, the anti-inflammatory cytokines like interleukin 10, they are high in the day, and inflammatory markers are high in the night. And what is the importance of this? And it's a confession. These pro-inflammatory cytokines, which is very high in the night, particularly interleukin 6, it's a double-edged sword. And because of this, the slow wave sleep sets in. And because of cytokines are high during this part, so during the early part of the morning where we are having a slow wave sleep, or little later part around 3 to 4 in the night, the chance of myocardial infarction, asthma, rhinitis, and joint stiffness of rheumatoid arthritis in the early morning are because of the cytokines are high in the night. And it induces slow wave sleep. And always we should remember the anti-inflammatory markers, interleukin 10 and 4, they are very high in the morning. So if you sleep intermittently throughout the day, throughout 24 hours, which I was hinting on, so you'll see that your pro-inflammatory and the anti-inflammatory markers will be errant. They do not know what to do. So they will straight go into a storm. And that can be due, these cytokine storm can lead to anything. So as you see, this is the brain cytokine cascade involved in sleep regulation. So this pro-inflammatory cytokines, which I was talking about, interleukin 1 beta, 6, 8, and 12, they work on stress hormones, and they work on your different pathway, like it works on the autonomic pathway, vagus, and your OVLT, your, these are circumventricular organs. And from the periphery, they give information to the brain. And the anti-inflammatory cytokines 4, 10, and the pro-somnogenic cytokines, they negotiate with each other. And this, in addition to other factors like growth hormone, releasing hormone, nitric oxide, adenosine, and PGD2, they create non-rapid eye movements, NREMs. So whenever you are sick, you sleep. Your pro-inflammatory and anti-inflammatory markers, when they're tossing in and they're dodging each other, the end result is that it leads to more of your non-rapid eye movement sleep, particularly your slow wave sleep. So increase in NREM sleep, why it occurs? It conserves energy. It suppresses REM sleep. You don't dream much when you are having high fever. And this is because it suppresses, REM is a paralyzed state. Your skeletal muscles, other than diaphragm, your orbital muscles and your internal auditory muscles, they don't get paralyzed, but the rest of the muscles, skeletal muscle, get paralyzed. And suppression of REM during any infection allows shivering and therefore the production of fever. You are able to know you are having some cytokine inside not working properly. And the fragmentation of NREM sleep reduces heat loss. So everything, as you see, always gives a chance to life. It is we do not understand the silent messages given to us by the body through different medias, because we are so much conscious to outside things than internal cues. So now the next is what happens, how the immunity changes during light phase and the dark phase. Let's look at this. During the light phase, you have high leukocyte number, and particularly the aged neutrophils are there in the circulatory system. And as we know that these cell adhesion molecules, which are again ruled by the circadian oscillations, is higher during the night. Because of these adhesion molecule increases in number during the night, what happens that these oldies, they are trafficked into the tissues, so that the youngsters are more there. the young neutrophils are more there, and the high leukocyte numbers are seen in the tissue level. And the aged neutrophils are trafficked from the circulatory system to that of the tissues. So there is more tissue infiltration in the night, good. Decreased circulation numbers so that not much of cytokines are released, antimicrobial activity, and decrease in vascular damage in the night. During sleep, you decrease your vascular damage compared to what happens in the day. So daily oscillations and immune activity during sleep is very interesting. As all of us know, physical and social environment, organismal stress, infectious stress, they lead to chronic and mild inflammation. Now, you know that the crosstalk between pro-inflammatory and anti-inflammatory cytokines. What they do exactly is disturb the sleep continuity by decreasing the total sleep time, decreasing the sleep efficiency, and disturbing your sleep architecture, which means decreasing your slow wave sleep. It should be 20% of your sleep time, and increasing your REM sleep time. And once your REM sleep time is increased, what happens is that a lot of energy is being conserved, though it is being conserved because of the total skeletal muscle paralysis. But during that time, many what you call physiological enhanced state happens. And this leads to increased inflammatory response and decreased antiviral immune response. So what are the increased inflammatory response if there is oscillations, daily oscillations are not maintained? Systemic inflammations, cellular inflammation, and so many things happen. But the most important, which we found now, was decreased antiviral immune response. So decrease in type 1 interferon response, so poor vaccine response, susceptibility to viral infections such as common cold, and susceptibility to pneumonia. This all happened because of bad sleeping quality. So last but not the least, sleep will heal. Short periods of sleep loss at the time of vaccination reduces the vaccine's effectiveness. Sleep loss is associated with increased obesity and with reduced level of leptin and increased level of ghrelin. Sleep loss is also associated with diabetes and impaired glucose tolerance in a dose-related manner. Individuals that report sleeping less than 6 hours per night are 1.7 times are likely, and those that report sleeping less than 5 hours per night are 2.5 times as likely to have diabetes than individuals that opt in 7 hours of sleep. Cardiovascular disease and hypertension are also associated with sleep loss. The risk of a fatal heart attack increases 45% in individuals who chronically sleep 5 hours per night or less. Obesity, diabetes, and cardiovascular disease are pathologies that are characterized in part by inflammatory processes. So we cannot forget someone in around quite their old days, Charaka. We have three great scientists, physicians of India, Charaka, Sushruta, and Bhagavata. And he has written that Nindriyatam Sukham Dukham Prishti Karya Valavalam Vrishyatak Klivata Jnanam Ajnana Jivitam Nacha. Happiness, misery, nourishment, emaciation, strength, weakness, virility, sterility, knowledge, ignorance, life and death, all these occur depending on the proper or improper sleep. See, so it's sleep sciences, maybe in the Western world it can be recent, but sleep science in India is very, very old. So some pearls here. Emerging intersectoral research on sleep, circadian rhythms, and immunity presents exciting opportunity for using scientific understanding to augment the immune resilience of shift worker and other at risk. So a deeper understanding may also aid in the development of regimens to maximize vaccine efficacy, combat infection, and optimize time of organ transplant to minimize rejection. We may discover that circadian rhythms are an essential clinical element that must be factored into health and prevention effort, as well as the diagnosis and therapeutic disease. Thank you so much. All of you are invited to my place where I work in Puri Jagannath Dham. This is my beautiful college. Thank you so much for listening to me. Thank you so much.
Thanks a lot, Dr. Arpita, for joining us and guiding us from very beginning and throwing light on sleep and immunity and the circadian rhythm. You well said that sleep is of the brain, by the brain, and for the brain. And you have thrown light on daily oscillations and immune activity during sleep. So it's a very enlightening and very enlightening for the UGs, PGs who are in a meeting room and those who are watching live on a mid-skill portal. Thanks for joining. I'm just waiting for an audience to ask any question. I'm just asking the audience to maybe they can unmute and they can ask the question, or they can post their question in the chat box.
Data collect किया, analyze किया, अगर वो data एक दूसरे से related है, it means significance.
Any questions?
Selected हो जाएगा. Otherwise, I will drop this. फिर इसके बाद आपका ये सब चीजें हैं, जैसे definition है, ये simple आता है.
We are getting the chat, the wonderful talk and good talk. Yes, of course, the talk was very good. Ma'am said that Nidrayan Sukha Dukha Pusti Karsha Valavalam. She have make very comprehensive understanding of all our ancestors' understanding regarding sleep and all. There is one question. Is there any role of melatonin in setting circadian rhythm? Is there any indication, ma'am?
Definitely. All of us know, as the sun sets, as we go into darkness, as the light entrainment decreases, the sleep inducer, in fact, it is not a sleep inducer, but it begins sleep induction, that is melatonin. So no melatonin, no induction of sleep. You cannot enter into sleep. So you will have a sleep induction insomnia. And in sleep induction insomnia, the most important drug which we use is only melatonin will help. You don't need to give any benzodiazepines. A sleep induction insomnia, you can give melatonin.
You are going to collect the data from you. A deductive approach
Dr. Jayanti is thanking you for getting her queries answered. Anybody want to ask question? Otherwise, we'll move ahead to our next expert audience. Okay, thanks, Dr. Arpita. We request
Thank you so much.
Yeah, we request you to stay with us. We are, yes. And now I am passing, my responsibility to Dr. Anwar Siddiqui. Dr. Anwar Siddiqui is assistant professor in the Department of Physiology in Jawaharlal Nehru Medical College, Aligarh Muslim University, Aligarh. And he is working for long as an academician. He is pursuing his PhD as well related to physiology and all. And he is a very keen researcher and all. And his forte is neurophysiology. So over to Dr. Anwar Siddiqui to take it forward from here.
Thank you, Dr. Nurul. It's been wonderful to be part of this session, this whole meet. And am I audible? Can anyone say, am I audible or not?
Yes, you are audible.
Okay, thank you. So, good afternoon, ladies and gentlemen. I am, as Dr. Nurul introduced, I am Dr. Anwar Siddiqui, Assistant Professor, Department of Physiology, Jawaharlal Nehru Medical College, AMU, Aligarh. And now I'll be taking over as the session moderator for the upcoming talks. So moving to our second talk. Now, for the past 2 years, we all have seen that all across the globe, people's life, their physical as well as mental well-being have been affected by the COVID-19 pandemic. The stress and strain of this pandemic has led to altered sleep pattern in many people, specifically in the healthcare professionals. The COVID-somnia or the corona-somnia, as it has been called, is definitely a thing to be worried about. And this is what we'll be talking in our next session. So in our next session, in our next talk, we'll be delving deep into the topic dealing with sleep during COVID-19 pandemic. And ladies and gentlemen, taking us deep into this topic shall be our eminent speaker, Dr. Bindu M. Kutty, Professor, Department of Neurophysiology, NIMHANS, Bengaluru. Professor Bindu, apart from being an academician and a professor at the NIMHANS, she is also the in-charge professor and coordinator of the NIMHANS Center for Consciousness Studies. She has been extensively involved in the research concerning neurobiology of sleep, meditation, and consciousness. And she has to her credit more than 100 research papers published in national and international journals of repute. She has numerous awards and fellowship to her credit. And if I go into details of all her achievements, perhaps it's going to consume much of our session time. So without any further delay, I welcome Professor Bindu M. Kutty for her talk. And the mic is all over to you, ma'am, now. Professor Bindu, ma'am, are you there?
Yes. Thank you so much.
Welcome, ma'am. Now the arena is all yours.
Can you see my slides? Hello?
Yes, they are visible.
Yes, ma'am, they are visible.
Okay, thank you so much. And I enjoyed the previous speakers, and Dr. Arpita is a close friend of mine. So hello to Arpita, hi. And I also thank all the organizers of Nascon, especially Dr. Nurul Anwar. I have been communicating with him. So this talk is, even though I have given the title dealing with sleep during COVID-19 pandemic, I just wanted to, here, we are just taking sleep as an index, actually, just to show that how much, this pandemic like COVID-19 affecting mental health as well as physical health. And so I thought I will just take you to the mechanism and what it could be, due to what are the mechanisms that really lead to sleep, poor quality sleep. That is the purpose of my talk. And this program, Nascon is organized in connection with the World Sleep Day. And if you look at the World Sleep Day, the theme, the quality of sleep, sound mind, and happy world. Whereas last year's theme also, if you look at it, is restorative sleep and happy future. So that means the World Sleep Society wanted to convey a certain message to the society that sleep is very important for sleep and health and well-being. If you have a restorative sleep night sleep, definitely you are very happy, very energetic, and very healthy. So you see the stark contrast. When you have a good night's sleep, you are very happy, healthy, and you can take care of, you can carry out all your wake-related activities very well, very efficiently, and there is no intrusion of sleep. So that means what exactly? Like, what do you mean by restorative sleep? I'll just come to this later. The previous speakers have already given all details about the sleep, like 7 to 8 hours and all. But I would bring this concept that we need to have enough sleep. So the definition now is that we need to have enough sleep to wake you up, to get up afresh. So that is the buzzword. But whatever, you may be sleeping for 5 hours or 6 hours or 8 hours, you have to get up afresh. If you can get up afresh, that means you can carry on with your day performance with efficiency, as well as that definitely will prevent the daytime sleepiness. So the key message here is that you need to have restorative sleep. So by restorative sleep, we mean that you will have had proper metabolic function, hormone and immune functions, cognitive functions, emotion regulations. So all these are happening during sleep. For example, I just give you a little brief about this restorative sleep. Then let us talk about the sleep changes during pandemic. So when we say that restorative sleep, see, this is a sleep hypnogram. And in this sleep this is one of a perfect hypnogram, I can say. There is a proper sleep continuity. with higher sleep efficiency, short sleep onset. You see that sleep onset is very, very short, and reduced number of awakenings. You are, only very little awakenings you can see here and there, but otherwise it is the very perfect sleep architecture. And short duration stage 1. See, stage 1 is very short duration, and longer duration stage 2. You see that stage 2 sleep is throughout, you can see. And also longer duration, deep slow wave sleep state. You see that you have a very deep slow wave sleep state, and usually slow wave sleep state happens during the first half of night, you can see especially, and even here also, but still usually the slower sleep state, especially deeper sleep state, occurs during the first half of night. And if you look at the statistics, we need to spend around 15 to 20% of our, the slower sleep. Then only we can say that it is we have had a restorative sleep. So when we say restorative sleep, definitely we need to have a proper sleep state with the proper duration of each sleep stages. Like, see, for example, we need to spend around 18 to 25% in the REM sleep state, almost 50 to 55% in the NREM stage 2 sleep, and 15 to 20% in the S3 deeper sleep state. So then only we can say that it is restorative. But still, when we say restorative, we always focus on the S3 state, that is the deeper sleep state. Why? Because the deeper sleep state, we can say that is the deep relaxation. It is that period usually your brain, mind, everything goes under deep relaxive state. You can see that neural activity comes down, metabolic rate is reduced, body temperature is reduced, sympathetic activity is reduced, and parasympathetic activity is very high. You know that parasympathetic activity is associated with the relaxation. So when there is high parasympathetic activity, definitely your metabolic activity will be reduced. The heart rate, blood pressure will be reduced. And at the same time, even you can see that cortisol is reduced, because sleep is inversely proportional to cortisol. So if there is an intrusion if cortisol is elevated in the evening, definitely that will interfere with your sleep. And definitely melatonin is high. Melatonin is also not only in induction of sleep, mainly for the maintenance of sleep. Melatonin is very important. So this is what when we say restorative sleep, you can see that it is a deep relaxation state. And at the same time, you can also see that there is a growth hormone secretion and other, melatonin secretion. So you see that all the feel-good hormones are, now going to be highly active, and it releases various feel-good hormones. And at the same time, all the other metabolic states are highly reduced. So this is what when we say that restorative sleep. And how do we achieve this restorative sleep? When you are having a proper sleep, you can see that there are many biological functions occurring in the body, like growth, maintenance, repair, immune function, network reorganization, memory consolidation, metabolic waste removal, and so on. So during sleep, we can say that, the lot of biological investment. So these activities, that is very important for maintaining a proper weight. So these are all very essential. And when you are having a poor sleep quality, all these functions are compromised. And also you can see, this also previous speakers have already spoken, that the metabolic waste removal. So metabolic waste removal happens according to the rhythm of your CSF. So CSF flow rhythms, you can see that this couples with the electrophysiological rhythm of the slow wave sleep. So when there is a slow wave sleep, that is during delta wave sleep, you can see that the coupling of this CSF flow occurs. So that means during sleep, almost if you read the scientific papers, you can see that the metabolic waste removal, 2/3 of the metabolic waste removal occurs during sleep than the wake. So that is the beauty of sleep. All the metabolic waste, especially including the toxic substances like beta amyloid, tau proteins, all these will be removed appropriately during night, during the restorative sleep states. And so that is why we say that when we say that restorative sleep state, that is definitely it has taken care of your metabolic functions, hormone functions, immune function, cognitive functions, and emotion regulation. So that is so this is just I want to highlight that, okay, like you have to have a restorative sleep. And this is, I just wanted to bring, to the new generation to read more about the various societies and their approach to sleep. So this is the Sanoy tribes in Malaysian Peninsula. The Sanoy tribes are supposed to be one of the happiest and non-violent people on this planet with near perfect mental health. And why I have brought this slide, because the Sanoy mothers, they encourage their children to dream in the night. And they also encourage their children to discuss the dream content the next day. And this practice of discussing their dreams and dream content definitely helped them to overcome all the worries, overcome all the anxiety, all the stress in them, and to attain well-being. So that is the beauty of sleep, actually. So you see that, in the modern society, I don't think any mother will ask their children whether you have had a good night's sleep or what dreams you have had. So these are all very good practices, and to make you a happy individual, like you can overcome all the stress, anxiety, and you can also enhance your well-being, enhance your health. So this is one of the examples just to show that the power of dreaming, and the power of dreaming at the individual level, and that how effectively it can be translated into social well-being. And especially in this present day world where there are a lot of conflicts are happening, these are all very important lessons for us to learn. And it is not only in the human society, even in the animals. This is also another example, the fruit flies. If the fruit flies are put together, that enhances their social interaction, enhances the fighting, courting, mating, flying, jumping, all these, they are so happy, and they also will have a restorative sleep. You can see that enhanced sleep out duration. So if the sleep out duration is more, that is an indication of restorative properties of the sleep when compared to the animals or the fruit flies in isolation. So when they are in isolation, there is a kind of isolation stress you are putting them into, and definitely their sleep also is affected. So you see that we have enough examples, and you can study a lot from these experiments on about the quality of sleep. Now, this editorial, I think I request all of the people who are interested in sleep science must read this. This editorial has come in the International Journal of Environmental Research and Public Health about on long-term health effects of 9/11 disaster of the WTC, the World Trade Center disaster, and these kind of disasters. You can see that we are affected by all these, and you can see that is reflected on the physical health, mental health, and the common symptoms one can study the sleep abnormalities. So here, I just want to highlight that sleep is just an index of your physical health and mental health. For example, even in the ongoing pandemic, there are various pandemics affected the physical health of the people as well as the mental. Like there are reports on post-traumatic stress disorder, anxiety disorders, and depression. And you can see these are all highly related. If there is sleep abnormalities, that enhances PTSD, enhances anxiety and depression. And if you are depressed or if you are highly anxious, that affects your sleep, good night sleep. So you see that all these are closely related. Now coming to COVID-19 outbreak, definitely it is one of the global crises in the 21st century. And definitely a lot of sleep-related issues during the pandemic has affected. So these sleep-related issues definitely affected our well-being as well as quality of life. And somebody was mentioning about the clinical insomnia, prevalence of clinical insomnia, about 35 to almost 50% in COVID-19 cases. So these are all just, I wanted to bring your attention that there are many international studies to show that how sleep has been affected by this pandemic in Italy, in China, in Finland, in so many places. This, especially even this prevalence of clinical insomnia has been studied in 13 countries and has observed that this is, we have had also, when I have searched, there is one study from AIMS also included in this particular study. So overall, if you see that the COVID pandemic is associated with the poor sleep quality, changes in sleep pattern, increase in frequency of nightmares, increased pandemic-associated dream content, increased stress level, increase the propensity towards negative mood, emotions, and daytime dysfunctions. So you see that if you have had a good night's sleep, you are very healthy, you are energetic, and you will not have all these physical or mental strain. Your quality of life improves, and definitely you can maintain your well-being. And also, I wanted to highlight that this poor quality of sleep also impede your emotional well-being. You can see that a lot of emotional disturbances, anxiety is associated with poor sleep quality, and your mood and your anxiety during the daytime is also affect your sleep. So there are many studies to show that bad dreams, nightmares, negatively charged dreams are related to poor sleep quality. Poor sleep quality, emotionally negative dreams and nightmare, frequent nocturnal awakenings, as well as fear falling asleep, again will lead to prolonged wake after sleep onset. So you see that how your sleep is affected due to all these emotional changes. And impaired sleep quality impact the emotional processing during wake. So you see that impaired sleep quality affect your emotions during wake, and these bad emotions affect your sleep also. So sleep quality is associated with the emotional regulation strategies, and negative effect is positively correlated with the poor sleep quality. So this is also very, very important that affect your mental health as well as the physical health. So in this regard, we have carried out, my team has carried out a survey, actually, just to see that what is the state of affairs about as far as sleep is concerned. And what we have observed is quite overwhelming. I'm so happy to see this, that people with dysomnia showed increased vulnerability to COVID. It is not that people have normal sleep, they are not worried or they never showed any vulnerability to COVID-19, but people with sleep disorders are very vulnerable to COVID-19 pandemic. So this is a questionnaire-based survey we have carried out. This survey was carried out using almost 50 Indians have participated in this survey, and the result is from 412 participants, and we have observed that 85% of the Indians are from South India, and almost we have got equal partners, females and males, and 91% of them are graduates, and 61% are on day shift jobs, and nobody was contracted with COVID infections. And the questionnaires what we used are from these different domains like socio-demographic, habit, sleep quality, daytime impairment, negative emotionality, sleep hygiene, and effect of COVID on quality of life, and so on. So what we have observed is that we have classified that into 3 classes. Those who are not having any sleep abnormalities or sleep related problems like no dysomnia, 38% of them belong to this class. Whereas there are almost 28% belong to this moderate dysomnia with frequent arousals with daytime impairment, high vulnerability to COVID-19 pandemic measures. Whereas the severe dysomnia, the class with severe dysomnia belong to almost 33%. And they showed daytime impairment, especially excessive daytime sleepiness and fatigue, negative emotionality, sleep initiation and maintenance problem, and high arousals. So you see that there is again a distinction between the moderate insomnia and the severe insomnia. And the severe insomnia constitute about 33%. And definitely the advocacy is that medical and cognitive interventions are very important. And the sleep problems include 22% of them showed sleep initiation difficulties, 20% showed sleep maintenance problem, 59% showed increased arousals. That mean intermittent awakenings during sleep that affect your sleep structure, sleep quality. 54% with the daytime impairments, excessive daytime sleepiness, fatigue, lack of concentration, all these, lack of attention, and so on. 20 to 22% worries, negative mood. So all like anxiety, negative mood. And thus, out of that, 26% COVID influenced their life attributed to sleep problems. So some of them are, they have also the perception that that COVID influenced their sleep problems. So that this belongs to this class, that severe dysomnia. So those who have showed severe dysomnia, felt that the COVID related problems are due to sleep problems. So this is also, point out that how important your sleep is. So now, in general, sleep deprivation ultimately leads to cognitive dysfunctions, attention lapses, impaired working memory, impaired decision making, impaired emotional processing, and various other things. So poor sleep, as Dr. Arpita has very clearly mentioned, that poor sleep is associated with many comorbidities like cardiovascular diseases, metabolic disorders, immune dysfunction, obesity, affective disorders, impaired daytime functioning. Now, being a neurophysiologist, definitely I wanted to know what happens to them, is there any neural signatures for all these, why there is a cognitive dysfunction, why there is emotional disturbances when sleep is disturbed. So the question is, what are the neural signatures of sleep deprivation? How does the sleep deprivation affect cognition and emotion? And what insight we can get it from these, so that we can also, develop certain remedial measures. So if you, I will just give you one references that is very important. It is worth reading that particular scientific paper. So the studies have shown that sleep deprivation is associated with disruption of a dopaminergic reward functioning. So this dopaminergic reward system is very important to maintain. When you get up early morning, your mood is, you are very happy and you are reward seeking, you are highly motivated. All these are because of this activation of dopaminergic reward system. So if you study this, you can see that dopaminergic reward system is highly active during wake. And it is because of that only you are very highly energetic, you are highly motivated, you are reward seeking, and so on. But at the same time, in the night, the dopaminergic reward pathways are very highly active even during sleep, and especially during REM sleep. And so REM sleep, you can see that for proper emotional functioning, this dopaminergic reward system should be functional. And when you are having a proper good night sleep, definitely the rich content of your dream depends upon the dopaminergic reward functioning. So there is again an interaction between synchrony or a coupling between dopaminergic system as well as with the cholinergic system. And it is these two systems ensure a proper dream sleep states. That is, it helps in initiation of the sleep state, REM sleep maintenance, as well as the REM dream content of the REM sleep. So dopaminergic system is very important. And also it makes you, for a proper social functioning as well as emotional functioning the next day. So you see the importance of dopaminergic functions during night. And if these dopaminergic functions are, disturbed during night, during sleep, during poor quality sleep, you can see that there is increased impulsivity, and increased impulsivity and increased hyperarousal. You can, and also increase the appetite dysregulation, like this also mentioned by the previous speakers, reduce the leptin and increase the ghrelin. So there is a appetite dysregulation and a tendency towards obesity, tendency towards metabolic dysfunctions that lead to other metabolic syndromes like hypertension as well as diabetic, and even substance abuse. So all these, you see that all these maladaptive behaviors just because of the disruption of dopaminergic functions. I will just come into that a little later again. And sleep loss and PTSD. In PTSD, you are very hyperarousal, hypervigilant during night. And hypervigilance, definitely it will interrupt with your sleep. And this hypervigilance is mainly because of the neurogenetic activation during REM. If you look at the physiology, you can see that during REM sleep, these hyperactive neurotransmitter projections systems like a noradrenergic system as well as serotonergic system are totally quiescent during REM sleep. But when there is a sleep loss, they will be very active, and that leads to even, you can see that in PTSD, there is a sleep loss and the nocturnal hyperarousal associated with the PTSD. Then there is cognitive impairment. Cognitive impairment is due to reduced frontoparietal network activity, thalamocortical activity, as well as DMN dysfunctions. Thus, we can see that sleep loss can be a predisposing factor associated with many comorbidities like addiction, anxiety, cognitive impairment, disturbances in motivational and emotional functions. So these are the things you just think, when you say that the COVID is associated with sleep, poor sleep quality, poor sleep dream content and all, you see it has impacted your brain functions, as Dr. Arpita put it. Like it is the sleep is for the for the brain, of the brain, and by the brain. So here there is a relationship between the FPN, the frontoparietal network activities, and DMN. Usually, when you are cognitively engaged, during daytime activities, you can see that there will be reduced mind wandering. DMN, the default mode network, is associated with mind wandering, is associated with self-related processings. Whereas FPN is a cognitively intent. This is very important for decision making. So there is an integrity. You can see that there is a network integrity associated with the sleep. And this network integrity is totally compromised during sleep deprivation. So when the network integrity is totally compromised, you can see that when you are concerned with a cognitively intense task, and where the FPN activity should be very highly active, that is now, you can see that there is reduced activity of the FPN and increased activity of the DMN. The DMN activity get intruded into your FPN activity, and that interfere with your attention and working memory components of cognition, and thus your cognition is compromised. So that is what is happening here. And the same way, there is a hyper vigilant, your reward system. So this is the reward circuitry. You can see that the medial prefrontal cortex, orbitofrontal cortex, as well as insula, they just send a very strong negative feedback to the ventral striatum and other reward circuitry. And in the absence of this, that is during sleep deprivation, this regulatory measures are totally compromised, and this system become hypervigilant. And when there is a hypersensitized reward system, definitely it impairs reward discrimination accuracy. And, that leads to enhanced impulsivity, increased risk taking, and so on. See, for example, high rate of gambling. Gambling is one best example of enhanced impulsivity and increased risk taking behaviors. So in gambling, there is increased risk taking behaviors and it is impulsive behaviors. That anyway, that is the system is definitely maladaptive. Maybe the system. Whereas here, in the case of sleep deprivation, you can see that it almost mimic that kind of gambling behavioral symptoms in the normal human subjects, like hypersensitized reward system, increased task-related ventral striatal activity, inaccurate cortical functioning, reduced thalamic activity, and reduced incentive processing with TFC. So you see that there is a total alteration of the reward pathway, and this leads to even, leads to various appetite dysregulation, obesity, substance abuse. In substance abuse, what is happening? You can see that there is a craving for, craving for this substance abuse. Like, for example, alcoholics, you take, alcoholics are, 80% of alcoholics are insomniac. So when there is insomnia associated with the alcoholic disorder, just to get sleep, they consume more and more alcohol. So this becomes a vicious cycle. And there is another like emotional instability or negative moods. What happens during sleepless, when there is sleep disturbances, your other brain region associated with this emotion regulation are also affected. For example, amygdala. So you can see that sleepiness induced by sleep that enhance the amygdala activity and subliminal signals of fear. So now, even if you are conducting a test in which you are seeing a normal face, you can perceive anxiety or negative mood even when you are seeing a normal figure. It is not only like the figures, like non-conscious figure happy conditions. you can see that the intensity of the amygdala activity is high due to sleeplessness, and so that enhances. So in response to a fearful expression, you can see that there is enhanced amygdala activity, and that leads to even a perception of fear even in normal condition, normal stimulus. So that is the thing. So there is enhanced amygdala activity to negative stimuli, reduced activity of medial prefrontal cortex that should regulate the amygdala activity, and that leads to defective functioning of the salience detection network. And definitely poor discrimination accuracy and overgeneralized emotional sensitivity. So you see that sleep deprivation interferes with the regulatory effects of medial prefrontal cortex and improper allocation of attention resources during an emotional task. So these are the neural signatures associated with the poor quality sleep. So definitely, I am just bringing these because you are the clinicians. So you have to think about it. See, when the patient comes to you and discuss about the poor quality sleep, definitely you have to think about restoration of these maladaptive behaviors just by targeted sleep restoration initiations. So in addition to your drugs, in addition to your pharmacotherapy, definitely these kind of rehabilitative procedures also you should think of, like targeted sleep restoration could be a possible remedy towards adaptive food choices, craving, and to overcome the impact of various maladaptive behaviors associated with the sleep deprivation. So I will just wind up my talk. So definitely the message is that sleep well to live life to the fullest. Thank you so much for patient hearing.
Thank you, Professor Bindu, for such an insight into the sleep disorder related to COVID. Now the session is open. The arena is open for a participant to ask their queries and questions. If they have any query and question, they can unmute the mic or they can write in the chat box. I'll be taking them. So as of now, there are no queries.
Thank you, Dr. Anwar.
Okay, thank you, ma'am. I think the audience, they have understood you fully and they don't have any particular query about your talk. So we'll move on to our next talk.
Yeah, thank you so much.
Thank you, ma'am. Okay. So for our next session, we'll focus on a very important topic, that is childhood onset sleep disorder. And to provide an expert insight on the topic, we have with us Dr. Nascon Goyal, Professor, Department of Psychiatry, Central Institute of Psychiatry, Ranchi, India. Professor Nishad, apart being an eminent academician, is also the program coordinator, mental health and psychosocial support during pandemic for Central Institute of Psychiatry, Ranchi. He is the Joint Secretary and founder member of Neuromodulation Society of India, editor of Eastern Journal of Psychiatry, and the review editor of Frontiers in Psychiatry, Child and Adolescent Psychiatry. He has to his credit numerous awards and fellowship. So without wasting any more time, ladies and gentlemen, please welcome Professor Nascon Goyal. The mic is all yours, sir. You can proceed with your talk.
Thank you, Mr. Anwar Siddiqui. Can you hear me?
Yes, sir, you are audible.
Thank you. So just allow me a moment so that I can share my screen with all of you. So I hope the screen is visible to everyone. I hope the screen is visible.
Yes, sir, it's visible.
Okay. Thank you. Good evening, everyone. So I've been invited today by National Health Academy to talk on childhood onset sleep disorders. So you must have seen that I work with children and adolescents, particularly in the clinical setting. So I thought that I'll be talking about this. So I would like to inform you that I also work as the lead principal investigator for Clinical Research Center and Clinical Research Training Program for Neuromodulation in Psychiatry, which is a Welcome DBT funded project which is run across 3 centers in the India. I would like to thank the Academy, in particularly Dr. Anwar, as well as my dear juniors, Dr. Nikhil Nair and Dr. Jitendra. I think Nikhil is currently in Noida and Jitendra is in Aligarh Muslim University, if I am not wrong. So that they suggested my name to the organizers, and that is how I am here, spending some time with all of you. So this is the place where I work. This is a 104-year-old mental health establishment, which is there in the Eastern India, a place called Ranchi. Ranchi is more, famous by the name of Mr. MS Dhoni, but CIP Ranchi is present even before Dhoni was born. So the objective of today's, my presentation is, just give me a moment so that I can just, the objective of today's, my presentation is that, I'll just take you very fast because we are focusing only on childhood onset sleep disorders. So how sleep changes during, various stages of life. What are the various pediatric or childhood onset sleep disorders and the comorbidities? What are the consequences? And what are the various behavioral and pharmacological options? So there's a disclaimer that this is purely a clinical talk. So I'll not be sharing any research or research details. So it will be purely for the purpose of, clinical work people are into. I'll not go into the details of normal sleep architecture. It's been talked about by various people before me or maybe after me. We all know what are the various phases of a normal sleep. So, what happens particularly in, young children or children and adolescent, there is a definite difference in the sleep architecture through various ages. It has been found that sleep becomes less efficient with age. What is meant by efficiency is that the quality of sleep, it deteriorates with time. Newborns sleep up to 16 to 18 hours per day in broken segments of 2 to 4 hours. They do not have any distinct stages. Circadian rhythm, madam was talking about, circadian rhythm and other things. It is not yet formed in newborn. By the age of 2 to 3 months, young children, they do develop circadian rhythm, various stages they develop. There is consolidation of sleep and the total sleep time reduces. Dreams are more apparent by 12 months of age, and the content usually in the early phase is vague. Coming on to the childhood, the sleep further reduces to around 10 to 12 hours, and it is more efficient in terms of there is long naps rather than shorter naps. Slow wave sleep tend to dominate the sleep cycle during this period of time. Children, they start to have vivid dreams, nightmares, content related to thoughts, fears, or desire which make them awake suddenly during the night. As the time passes, as a child enters into adolescence, the overall sleep period reduces to around 8 to 10 hours. This is very, very theoretical. These days, things are completely different. We can talk about it. We can discuss once I finish with my presentation. There is decrease in the slow wave sleep with onset of puberty and more into adulthood. So there is an intersperse between slow wave sleep, then REM, then slow wave, then REM, and that is how it goes on. And these are the various physiological parameters which happen during non-REM and REM sleep. I'm not going to the details of this because I'm sure my previous speakers have already spoken about all these things. So what happens to muscle tone, blood flow to the brain, respiration, airway resistance, so on and so forth. Now, quickly setting on to the various childhood onset sleep disorders. So when we talk about sleep disorders with the particular onset during childhood, we usually talk about obstructive sleep apneas. Again, it is not that common, but yes, we do have. I'll talk about it. Then sleep-related movement disorders, which are very, very common in young children, particularly parasomnias, particularly narcolepsy, circadian rhythm disorders. Again, circadian rhythm disorder is one great pandemic which is going to happen as the COVID is fading now. Then there's something called behavioral insomnia of childhood, various psychiatric and medical causes which may lead to sleep disorders in this young population. So first, talking about obstructive sleep apnea, we all know what are the clinical features of obstructive sleep apnea, OSA as we call it. We have snoring, apnea, enuresis, feeling of unrest leading to waking up, daytime somnolence, and long term, when it continues, it can cause cognitive dysfunction. In young people, it is most commonly seen secondary to adenotonsillar hypertrophy. We all know that tonsil or adenoid glands, they cause a lot of problem in growing children. Obesity is a very, very common feature. Then people with neuromuscular disorders like CP or Down syndrome can also have. Risk factors, particularly in the world of pollution these days, allergy is a major risk factor, sinus issues, Australian American ethnicity and family history of obstructive sleep apnea can be one of our major risk factors. It has been found that OSA can also be associated with attention deficit hyperactivity disorder. There's a hypothesis which is proposed that intermittent hypoxia plus fragmented sleep can lead to prefrontal dysfunction, which is a cardinal manifestation of ADHD. How do we diagnose? We diagnose usually by polysomnography and pulse oximetry. Treatment includes weight loss, tonsillectomy if it is indicated, CPAP. I'm sure you all know about all these things, and medicines like leukotriene receptor antagonist. At times, intranasal corticosteroid is usually not required, but at times we can use that. Then something is a very old method, external nasal dilator strips. Then coming on to the next section, which is called sleep-related movement disorders. Now, in this particular section, I'll be talking about four ways where we can describe it. One is the rhythmic movement disorder, PLMS. We all know what is PLMS, periodic limb movement disorder of sleep, restless leg syndrome, and what is the association of PLMS and RLS with a very common, it is the commonest childhood disorder, that is ADHD. First, talking about the rhythmic movement disorder. It is also known as Jactatio capatis nocturna. This is the old name of RMD, which is characterized by repetitive stereotypic movements which involve large muscles. Now, when the large muscles are involved, it may lead to head banging, head rolling, or body rocking. Now, head banging, and I must tell you, if people who are working in pediatric setup or who are working in child adolescent psychiatry, they'll find this complaint very commonly coming that children, they bang their head whenever they are stressed out or when they are made to lie down in prone or supine position. It's more common in boys and in the first year of life. Head rolling is more common than head banging, and it lasts over a period of time, but it usually wanes off with age. The hypothesized mechanism behind this rhythmic movement disorder is, first, the most common one is self-stimulation or self-soothing. At times, I'm sure we all must have done also during our childhood that by rocking, we would fall asleep more easily. So these are the ways we do it. It is more commonly seen in infants and children less than 5 years. Usually occur when the child is sleeping, either in stage 1 or stage 2. Particularly, children with mental retardation, as they grow, they might present it as a self-stimulating behavior. We diagnose primarily through clinical evaluation and or video polysomnography. In this condition, we should also rule out seizures. Management is mostly supportive. It usually goes off with age in most of the cases. If they are causing injuries, we should provide padding, protective helmets at time, particularly in children with CP and mental retardation. And we should allow at times child to engage into rocking before sleep. I'm sure many of you do with your children, or you were done with by your parents. Rarely we do give low dose benzodiazepine in such cases. Next, coming to the PLMS, it is more, again, it's a briefer, it's brief, jerky, involuntary, at times non-stereotypic movement, lasting for few seconds only. More common in lower limbs than the upper limbs. And as children, the moment they become less apparent, the complaint, older children, they complain of pain, discomfort of the leg, disrupted sleep because of the movement, or at times difficulty in initiating or maintaining sleep. PLMS usually is associated with increased rates of parasomnia. Diagnosis the same way. We have to rule out seizures and OSA through detailed history. The management, again, is very non-specific. Usually in such cases, there is low iron, so we give iron supplementation. Rarely dopaminergic agents like ropinirole or pramipexole are prescribed. Adult PLMS, usually, it is not my, forte right now, but bupropion is an antidepressant which is seen to be effective in adult PLMS. Again, benzodiazepine have a very limited role. Coming on to the restless leg syndrome. Again, restless leg syndrome is a common comorbidity with PLMS. So what I mean to say that they do coexist, they occur together. Now the complaint is very non-specific growing pain or going on pain or leg discomfort. The criteria include urge to move legs, maybe the upper extremity more than the lower extremity. It worsens or begins when a person is sitting, lying, or remaining inactive for some time. The urge is partially or totally relieved upon movement, and that is why it is called restless leg syndrome. It occurs usually in the evening or night. At times, it is more severe than during daytime. It causes difficulty in initiation or maintenance of sleep. Anxiety is a very, very common symptom associated with restless leg syndrome. Because we are talking about children and adolescents, so management primarily is behavioral intervention, including strict sleep hygiene and regular physical activity. Again, iron supplementation and drugs like benzodiazepines, clonidine, they are more used, or they are more approved for use in adults. Now, coming to the last part of this section, that is basically about relationship between symptoms of ADHD and PLMS. As I said, PLMS, RLS, they coexist, and they are very commonly associated with ADHD, particularly when the child is growing into early adolescence. There are various hypotheses which have been described in terms of impairment of dopamine pathway, iron reduction in iron, and so on and so forth, leading to decrease in the dopamine production. There are other things. I'll not go into the details of this. Iron supplementation has been shown to improve both PLMS and RLS in ADHD. Moving on to the next major section, that is the section of parasomnias. I'm sure we all know what is parasomnia. Para is different, somnia is sleep. Parasomnias are one of the most common problems which are largely seen in children, and they appear to spontaneously resolve with age. I'm sure we all must have had nightmares, night terrors when we were young. It is hypothesized to be associated with or secondary to CNS immaturity. As the brain is growing, parasomnias, they improve in most of the situations. Unless proven otherwise, parasomnias are benign, and at times they may be impairing, particularly in older children if they're functioning with social functioning. Particularly these days, children go for sleepovers, and if the friends, they come to know that they're having night terrors, so it is very, very embarrassing for those people. Parasomnias are broadly divided into two: non-REM parasomnias and REM parasomnias. So we'll take it one by one. Non-REM parasomnias are also known as arousal disorders because of sudden awakening from deep slow wave sleep. And usually the child presents with confusion and retrograde amnesia. When you ask about it, they don't remember what has happened at that time. During this period of awakening, they do not respond to external stimuli. It is associated or may be associated with autonomic or motor hyperactivity. There will be movements associated with that. Very frequently, there is a positive family history of parasomnias, particularly history of sleepwalking or night terrors. REM parasomnias, they are not particularly associated with confusion, or people might remember or recall what happened during that time. The common examples are nightmares, REM behavior disorders. REM behavior disorders more commonly are seen in adults or maybe in older, adolescents also it can be seen. REM parasomnias are also associated with intermittent sleep paralysis, or in other words, which is called cataplexy. We should rule out, in such cases, we should always rule out whether the person is or the child is having seizures, especially in history when you get that the duration is very short, movements are repetitive, stereotypic, and there are inconsistencies in the pattern of episode. Most commonly occurring parasomnias in this young population, it includes sleepwalking, night terrors, nightmares, and nocturnal enuresis. So we'll take these four things one by one. First is sleepwalking, or in technical terms, it is called somnambulism. Exact pathogenesis is not known. It involves complex coordinated motor movements and cognitive functioning. You'll not believe, it has been reported that people have even walked for long distance. Even people have driven their vehicles also. This is in adults, of course. They have driven their vehicles during the sleepwalking stage. It is most frequently seen in pubescent children, particularly around 12 years or around, but usually carry on to adulthood. Typically seen in the first third period of sleep. It is triggered by psychological or physiological stress, particularly most commonly sleep deprivation. There will be increased rates where you have comorbid OSA, migraine, and something called Tourette syndrome or Tourette disorders. Very uncommonly, they are associated with aggression, but they may become combative and agitated if they stop. Like children, they do become irritable, agitated. They become violent also when they stopped during the episode. How do we manage it? Largely, the management is supportive. We should focus on ensuring that the child doesn't injure themselves during the episode. As we said, that we should try to limit the interference. We should remove some objects if they're on the way. Try to schedule these sleep awakenings. It is possible if you try to nap out things. I think a videography at times helps. Psychological management, particularly if it is secondary or resultant due to stress, relaxation techniques. Some people, particularly in the middle and late adolescence, they use benzodiazepines and antidepressant. But mind it, there are only anecdotal reports of using antidepressant, particularly when there is clear-cut evidence on polysomnography that there is impairment in REM, sleep. Then night terrors or power nocturnus. The same way, first third of sleep associated with loud screaming or crying. At times, it is very difficult to console. They are present with increased autonomic activity and intense feeling of panic and anxiety during the episode. They usually last for less than 30 minutes. And very, very specifically, which differentiates it from nightmares, is that there is little or no recall of event. They may or may not be associated with sleepwalking, usually between the age of 3 to 7 years. Family history is more or less present in such cases, and it is further triggered by fatigue and stress. There are two types. One is type A, which is usually more common and benign. There is no treatment required, but parent reassurance is given. Aapka bachcha theek ho jayega. This is what we tell. Type B which is frequently secondary to any trauma. It can be a psychological trauma, emotional trauma, physical trauma. This might persist throughout life, particularly children with abuse. They have this type of night terrors. Usually it is very, very difficult to treat, but we do give low dose benzodiazepines and tetracyclic antidepressants like imipramine. Nightmares are commonly seen in both children and adolescent. In children, more during the same age as of night terrors. We should distinguish them with night terrors because in nightmares, usually there is a recall and they are not associated with confusion, more commonly seen during the second half of sleep or REM period. Treatment is again the reassurance of the parents. At times we provide, we offer progressive muscle relaxation, dream scripting. Pharmacological treatment includes prazosin or clonidine. Prazosin is now not used these days. Now, very, very important, which we commonly come across in our day-to-day clinical practice is called nocturnal or nighttime enuresis. I'm sure we all are aware of DSM-5, where it is diagnosed as a repeated involuntary bedwetting while sleeping, which is present for more than 2 times per week for 3 consecutive months, causing significant impairment in those children where the toilet training is complete by the age of 4 to 5 years. अब आप 2 साल या 3 साल के बच्चे में नॉक्टर्नल एनुरेसिस डायग्नोज नहीं करते हैं, माइंड इट. It occurs proportionally throughout the sleep stages. ऐसा नहीं है कि किसी एक स्टेज में होगा. It is usually not associated with sleep disruption or arousal. Again, there is a primary enuresis where there is a strong family history, more seen in males with neurodevelopmental delay, usually because of delayed maturation of bladder control. Secondary enuresis, it usually presents with wetting episodes after a sustained period of complete dryness, which is more common. Usual causes are medical or psychological. You can see the medical causes. I'll not repeat them. Psychological causes, they include death of someone in the family or bereavement, trauma, bullying. It is at times associated with sleep apnea. And usually, particularly in such children, if you do a tonsillectomy, it also improves. Management primarily is behavioral modification. These are the various techniques I have listed. You can see these techniques. Drugs like oxybutynin, tricyclic antidepressants, and DDAVP, arginine vasopressin, intranasal spray can also be used. Moving on to circadian rhythm disorders, which are more common or more talked about these days, particularly during and after the COVID-19 pandemic, because of using mobile, TV, and other things. We all suffer from delayed sleep phase syndrome, where our sleep schedule lags behind the environmentally accepted sleep schedule. And Madam has already talked about it, so I will not go into the details of this. I can just tell that this is more commonly seen in adolescents than children. Treatment includes systematic sleep deprivation. Melatonin can also be used, but again, just prescribing melatonin will not work. The patient has to be told how the melatonin has to be used. And I'm sure many of you might be aware of the method of using melatonin. Then the other one is the sleep phase advancement, where sleep occurs earlier than the expected schedule time. It is less common than the delay one. Again, delaying the sleep by a few minutes, at times it helps. Then irregular sleep, when the things are intertwined or mixed, we call it irregular sleep or sleep-wake patterns. They're usually caused by irregular schedule and lack of consistent structure at home. Some children, they do have a shorter sleep cycle, maybe through genetics or through the way they have grown up. They do not have difficulty falling asleep or waking up during the morning. Then coming to behavioral insomnias of childhood, or these are also known as sleep onset association disorders. Children have difficulty. There is a group of children, they have difficulty falling asleep independently. They need rocking, TV, being with parents, being held, sleeping with parents, having a bottle. I'm sure you must have seen around you, especially prevalent in infants who are associated or there has been a history of falling asleep with parental support. We usually use awakening shortly before the predicted time, to remove this. This is called, contingency management or behavioral modification. There's something called limit setting disorder where, parents, they do allow them to stay up later. Particularly, I've seen in business communities where, people come late after, and children, they wait for their parents to spend time with them, and they develop this problem. At times, the combined type, feeding related disorders, and poor sleep hygiene. Very quickly, I would wind up in the next 5 minutes. The various psychiatric disorders, they are also associated with sleep related problems in young children, particularly depression or mood disorders associated with early morning awakenings, increase in the latency of sleep, interruptions. Anxiety is associated with similar problems. We usually treat them through environmental interventions or behavioral modification. Alcohol or drug abuse in young children at times is associated with sleep-related issues. Similarly, PTSD, ADHD, they are also associated with various various sleep-related conditions like parasomnias or sleep-wake cycle abnormalities. So now, psychiatric causes, what can be the causes? 5 factors have been consistently seen in various studies where children, they grow up with sleep issues. First is a family member who has either met with an accident or an illness, unaccustomed or unprepared absence of mother because of anything, mother suffering from depression. When the children and adolescents, they sleep for a long time with their parents, and when the mother is not sure about how she is going to grow up the child. So these are the various conditions. Medical causes include colic. Colic is a very, very common cause of children from 6 months to 5 years of age. So I'll not go into the details of sleep hygiene. We all know, it is a bit different when it comes to infants, early adolescents, late adolescents. People will be talking about it. So I'll not go into the details of this. Just a brief word about evaluation of sleep disorders. At times, etiology of sleep is, problems in pediatric population is multifactorial. Detailed history is imperative. We should, mobilize the parents to keep a sleep diary for at least 2 weeks. There is an example of having, and we can use various questionnaires like adolescent sleep hygiene scale, children's sleep habit questionnaire. They're particularly developed on children and adolescent. As per, the requirement, we should do a medical workup. We should do a comprehensive physical examination. Iron levels at times, they do help. And as I mentioned previously, polysomnography may be required if you're suspecting a primary sleep disorder. Depending upon, the complaint which they present to us with, suppose a person is having difficulty falling asleep, you should always, look for schedules of various naps, family history, association with fear, worries, difficulty sleeping, maintaining sleep at night because of awakenings, so on and so forth. Whenever a person presents to us with poor sleep routine and sleep hygiene due to environment and psychosocial variable, always look for that whether there is a regular light, noise, or temperature changes in the housing. What are the activities a person performed during the bedtime? These days, using telephones, particularly smartphones, computers, TV. So it's very common, always, particularly in adolescents, always ask for substance use if they're into it. They usually don't tell this in front of their parents, so you have to talk to them alone. Involvement of parents, in the sleep hygiene, maintaining sleep hygiene. It's not that you only ask your children to, have sleep hygiene. You have to set up an example for that. The ramifications, particularly the long-term ramifications, they include neurocognitive deficits in attention, memory, and learning. Children, they become impulsive, hyperactive, more in younger children. They have difficulty in executive functioning, daytime sedation. More and more, they can develop irritability, oppositional defiance, anxiety, fatigue, and depression. So I would like to end my presentation with this slide, which talks about various complaints which we do come across. I would like to say that children and adolescents, they do complain of various sleep related issues, and we should be aware and mindful of how we are going to do assessments and provide them proper solution. Please use your mobile phones judiciously, because children, they learn from us only. So thank you very much. With this, I am stopping my screen share, and I'm happy to take questions if there are any. Over to you, organizers. Thank you.
Thank you, Dr. Nishad, for such a detailed and engaging presentation on the childhood disorders. So the floor is open now for question and queries. Audience, you may post your queries in the chat box, or you may raise your queries here by unmuting yourself. Do we have any query? Okay, Jayanti Prabhasa has asked dose of melatonin in pediatric patient. She wants to know the dose of melatonin in pediatric patient.
Yeah, we usually, refrain from using melatonin in children less than 5 years of age. But if it is required, we usually start with 1 milligram per day. We can go maximum up to 5 milligram per day. 1, 3, and 5 are the doses which is available in the market, so we can give that accordingly. I mean, there is a recent literature where people have used melatonin, particularly in sleep-related problems associated with autism also. So, but again, I would not suggest that we should use it in children less than 5 years of age.
Any more query? Okay, sir. So there seems to be no more query from our measures to be taken for sleep hygiene. Another query from Jayanti is measures to be taken for sleep hygiene, sir.
I did not. I had included the slide, but for the sake of managing time, I did not, because we all know what are the measures for sleep hygiene. If you just Google it, you see YouTube University or WhatsApp University, you will find so many videos and memes on that. Simple things. Please don't use your bed for watching TV or using your smartphone or mobile phone. Don't eat food very late. Don't it's not a bad idea if you can take a quick bath with warm water before going to sleep. Try not to use light while you are sleeping, but the room should be in such a way that whenever the sun sets up in the morning, you should get some amount of sunlight. And try to have the same bed or the same place where you're sleeping. Don't change it very often. So these are some basic things. And I must tell you, before teaching others sleep hygiene, please first do yourself. Please follow sleep hygiene yourself, then teach your children and adolescents. Thank you very much.
Okay, thank you, sir. Now, since there seems to be no more query from our audience, and also we are running short of the time, so we'll move on to the last talk of our session today.